The final day for psychiatry. I hope all of you are having energy, full of energy. So we are going to discuss child psychiatry. So before discussing this topic, let us take a moment and remember our parents, our guardians, who have helped us reach where we are, right? And please remember that there is only one thing: they don't want money from you. They don't want anything else, but they want you to be happy. So this is the ultimate aim of all of us. Okay. So let's be happy and study psychiatry. Okay. So child psychiatry. This is a very important topic. A lot of questions have been asked from this topic recently. Very, very important topic. Right? So we are going to discuss important disorders, how to identify them, and how to manage them. Right? So the first important disorder which we are going to study today is attention deficit hyperactivity disorder, also known as ADHD. Okay, so name is telling you the symptoms. That, as I always say in psychiatry, names will tell you the symptoms. Names generally tell you everything. Okay, so these are basically, so child psychiatry disorders are having an onset in childhood, right? So, isn't it from the name only, it is very clear what are the symptoms? Attention deficit, problems in attention, and second there is hyperactivity. So my child is not able to pay attention, he is very hyperactive. These are the symptoms with which the patient comes to us, right? So what are the clinical, so before this please understand, these are neurodevelopmental disorders. Neurodevelopmental disorders. Okay. What do I mean by neurodevelopmental disorder? That means there is some neurological basis. Developmentally, there is some problems in the nervous system neurologically, which is leading to the symptom. It is important to know this because many a times, parents come to us and say, doctor, he is doing these tantrums. This child is mischievous. He is not behaving properly. But please understand, this is not that the child is doing intentionally. This is something which is, so someone is having fever, you will not say, oh, this is fever is produced by it. No, it's a physiological thing. Similarly, these symptoms occur. The child is not behaviorally producing these symptoms. So it is very important to know. Okay, so let us discuss the symptoms. So clinical features. First is inattention. Inattention. Remember in MSc we were discussing attention, ability to focus on a particular stimulus. This child is not able to pay proper attention. Okay, so he is inattentive. Okay, so if he is sitting in the class, he is looking here and there. He will not be able to pay attention to what the teacher is saying. Okay, so this is inattention. So what kind of complaints the family members will say? They will say, doctor, he fails to give close attention to details. Okay. So teacher asks the child, stand up, open your book, go to chapter 5, para 6, line 3. So much details he is not able to grasp. He is not able to pay attention. Right? He makes careless mistakes. A lot of, the parents will say, doctor, he makes very silly mistakes. We tell him something as if he is not understood what we have spoken. So he makes a lot of mistakes. Even the teachers will complain. This child is easily distracted. Okay. So again, the teachers will complain, the parents will complain that, he's for 1 second he's listening to the teacher, suddenly there is a noise outside, the attention shifts there. Suddenly there is a noise here, attention shifts there. So they are not able to pay attention. So parents will say, doctor, when he's watching television, he's not able to pay attention for a long time. He keeps on changing. And impulsivity. So hyperactivity is already, from the name itself, and also these children are impulsive. In which other condition can anybody tell me? We had discussed increase in the activity. Very good. sometimes, when a child comes to us with mania, sometimes, we have to, make the diagnosis carefully. Okay, even children can have mania. Yes, children can have mood disorder also. We have, children coming to our clinic at 6 years, 7 years, 8 years having depression, mania. So yes, even those disorders can occur even in children. So we're not talking about those disorders. Those can occur in both. But now we are specifically focusing on childhood disorders. Okay. So in hyperactivity, what will happen? He will fidget, keep on fidgeting. He's sitting, just, he's not, as if, he's not able to stay calm. Or the child will keep on tapping hands and feet. If the child is standing, he will not stand properly. Keep on doing like this. Keep on doing like this. Okay. They will be fidgety. They will not be able to stand. They will not be able to stay, stand at least. In the school, they will be able to. Okay. Then they will leave seat in situations when remaining seated is expected. So all of us are sitting in the class, remaining seating is expected out of all of you, but you will just stand up. The child if comes, stand up, keep on moving around. Okay, so there is hyperactivity. The parents, come with very, typical complaint. Sir, as if there is a motor inside him. Please tell us the switch off button. No, कोई motor लगी हुई है. He just keeping running around here and there every time. Okay, we go to a party. All the other children are sitting and he is roaming around. Okay, go to a movie theater. You will see one or the other child. Just roaming around. Parents, tired parents are just running after. Okay, so they, they are continuously moving. So they are acting as if they are driven by a motor, and also they are impulsive. They will have difficulty to wait for their turn. Okay, so you ask them to stand in a line, they will not be able to. They're very impulsive. You are asking them something, even before you have finished the question, they will answer out something. So they are very impulsive. Okay, so one symptom is inattention, and the other is hyperactivity and impulsivity. I hope you are able to understand what I mean by these two symptoms. Because one question in ADHD is to make the diagnosis. So in ADHD, two type of question comes. One is you have to make the diagnosis. They will give you, this is a child, these are the symptoms, right? Everyone understood this? Just see if you have missed anything here. So the child is never still. He's always, even if he's sitting, he's doing like this. Continuously active. Okay, moving. Okay, so this is hyperactive. Now, in the diagnosis, other than the symptoms, two important things I want you to remember. So in the diagnostic criteria, now these symptoms should be present for 6 months. Okay, again, we'll not go into the details of those, but there are two important changes which I want you to remember. Okay, so this is according to the latest DSM-5. Okay. So according to DSM-5, so in the diagnostic criteria, two important things we need to remember. One is that the symptoms have an onset before, prior to what is the age? Can anybody tell me? Very good. 12 years. Very good. So that what I mean by this is, that means that to make a diagnosis of ADHD in a child, understand it's a childhood disorder. It should start in childhood. So we are saying that if you are making a diagnosis of ADHD in any child, the symptoms should start before the age of 12 years. Okay, everyone got this? Okay, so we have a patient, let us say 15 years age of a patient. We have a patient who has come, 15-year-old male, family members are brought, and they say, doctor, in 6 months he's inattentive, he's hyperactive. Is it ADHD? No. It can be mania something else, but it is not ADHD. Because the symptoms should start before 12 years. Okay. Why this is important is because earlier this criteria was 7 years. Now this has been removed. Earlier it was 7 years. Okay. So that is why you need to know this change. It is 12 years now. Very important. Okay. And second is The symptoms should be present in how many settings or situations? Very good. At least 2 settings. Settings means 2 situations. So let us say parent says doctor says doctor at home he is having these symptoms. Also we are getting complaints from school also. 2 settings there? Yes. Symptoms at school, symptom at some neighbor's home. Symptom at home, symptom in a park nearby. So at least 2 settings. Because many a time we see, when we have many patients who have symptoms only at one situation. These symptoms can be because of some behavioral issues, right? So, don't be in a hurry to make the diagnosis, right? It should be, so again, these 2 points are very important. Now, if I ask you, ADHD is more common in boys or girls? Very much more common in boys than girls. Much more common. Okay. Although yes, also in girls, but much more. In fact, most of these childhood disorders will be more common in boys. I'll tell you some exceptions. Okay, but mostly more common in boys. Okay, right? Now, depending on just like in OCD, I told you, depending on the predominant symptom, it could be of 3 subtypes. Just like in OCD we discussed, it could be only obsession, only compulsion, both. Same way here, it could be combined presentation. It could be combined, that is both inattention and hyperactivity, predominantly inattentive and predominantly hyperactive impulsive. Okay. So even if in the question they are just mentioned symptoms of inattention, then also it is ADHD. Okay, only hyperactivity symptoms are there, then also it is ADHD. So this is the reason I am telling you this. Sometimes they may give only one symptom. Okay. Anybody seen ADHD case? Anybody seen any ADHD case? Neighborhood nearby? Have you seen? Okay. If you see, you will never forget. No, many times when a case of ADHD comes, I'm sitting in my cabin, from outside only I'm able to say, okay, it seems to be, because the child will be very difficult to handle by the parents. Even if he sits, comes in a cabin, he'll be roaming, so we have to, remove all the things, so that otherwise he'll be just, picking up anything, moving around. Okay. So, just by seeing, you can at times make the diagnosis. Okay. Now, coming to the treatment, if I ask you, what is the treatment for ADHD? How many of you say therapy, psychotherapy? How many of us say therapy? So we should do therapy, we should do, okay. And how many of you say drugs, medicines? Okay, good. Both? No, not yet. So if you are asked, there are certain disorders in child psychiatry where medicines have a very good role. There was once a question, a child with these symptoms, diagnosis of ADHD, what should you tell the parents? It's a behavioral problem, don't worry. It's a problem which can be solved by therapy. It's a serious problem, start medicine. What will you say? It's a serious. When I say serious, I'm not saying it's a life or death situation. Please understand. I'm saying a child in his young stage, he's not able to pay attention at school, at home. In his learning years, he's not able to pay attention. He's missing so much crucial time. It's a very serious condition. And drugs have very good role. Very good role. Let me tell you, there are certain conditions in which drugs have very good role. This is one of them. So, treatment of choice is pharmacotherapy. Right, so we'll make a small table. So we'll make a small table in this. Will become very handy. We'll make a small table. Many questions will be solved from this table. First question, treatment of choice, if you are asked. Pharmacotherapy, psychotherapy, it is pharmacotherapy, right? Now there are 2 groups of drugs which we use. One are the CNS stimulants. Okay. So first are the CNS stimulants. Okay, so make a table just like we are making so that it will become very easy. And the other is non-stimulants. Okay, stimulants and non-stimulants. Right. If I ask you out of these drug of choice, if you are asked between these two groups, yes, the drug of choice, if you have to be more specific, it is CNS stimulants, prefer over non-stimulants, right? Now, 2 points about stimulants I want you to remember. One is they are contraindicated in cardiac illness. They are contraindicated in cardiac illness. Okay. So they are contraindicated. This is very important. Suppose they tell you that there is a family history of sudden death in the child. That means they are trying to tell you there is some possibility of cardiac risk in the child. Don't use stimulants. Okay, so many questions will be coming from these clinical scenarios. Second is, tell me which time of the day you should avoid giving stimulants. Very good. In the evening or in the night. Why? They are stimulant. Why do you drink coffee or tea? When in the night you are falling sleepy, why do you drink coffee, tea? You want to remain active. It has coffee, tea has caffeine. Those are stimulants. Okay. So stimulants will keep you awake. So we ask the family members to give the dose in the morning when the child is going to school, or if it is divided doses, give the second dose when the child comes back from school. Okay. So it should be avoided in the night because of risk of insomnia. Okay. Very simple, basic, problems which can come as questions. Okay, so these should be avoided. If I ask you now the drug of choice, I told you drugs are the drug of choice, treatment of choice. No, it is. Which one is written first? Methylphenidate. The drug of choice. The drug of choice. If you have to choose, right? 2 important side effects I want you to remember. So you started the patient with methylphenidate. Mother is very happy, parents are very happy, sir. Everything is going fine, 6 months, all good. But sir, nowadays is making such movements or such vocalizations. He's making such movements. He says that he knows he is doing it, but he's not able to control. He's doing such movements. What are these? These are tics. So these can precipitate or increase tics, right? So tics can be motor or vocal. Motor or, anybody seen movie Hitchhi?
Yes, sir.
Yeah, so it was Tourette syndrome, tic disorder. Okay. Okay. So you tell the mother, okay, I know this drug can cause it. Okay, so you may change the drug. Second complaint, the mother says, okay, doctor, one more thing I want to tell you. That his ADHD is all well, but when I see him, the other children of his age are growing, but as if he's not growing. So what will you tell? Oh, since I am the first year resident, I forgot to tell you that there is one more side effect. What is it? It can cause growth suppression. It can cause growth suppression. Mother is very worried. Oh my God, doctor, what shall we do? Will my child grow again? We said, don't worry, don't worry. If growth suppression occurs, we can continue the drug. We'll just follow a strategy known as drug holiday. We don't have to stop the drug. We will follow a strategy known as drug holiday. What is drug holiday? We will give the child holiday from drug. Okay, on weekends the child is not going to school, he's at home, stop the drug. In summer vacations, winter vacations, stop the drug. So during that time, the growth will come back. Okay. So these are 2 important side effects which you should remember about methylphenidate. Right. Second drug is amphetamine. Second is amphetamine. Again, amphetamine is also a good drug, useful drug. But one thing you should remember, amphetamine we will also discuss when we will be discussing substance use. It has addictive potential. Okay, so it has addictive potential. So if you get in a family, there is history of alcohol dependence in the father, there is history of alcohol dependence or any other dependence, okay, then again you may avoid amphetamine, okay, because again amphetamine also becomes addictive at times, okay. And the last drug is modafinil. Modafinil, of course, many of you might have heard the name. Okay, you are feeling sleepy, give me some drug, I want to be awake. Many a times students also come to us and say this. Okay, modafinil. But it's not that every one of us should consume modafinil. It's not, so modafinil. It's again a stimulant. Okay, it's a alpha-1 agonist. It's an alpha-1 agonist. We will discuss modafinil again when we will discuss sleeping disorder. Yes. Good. Okay. So please remember this. These first two are FDA approved drugs. They are approved by FDA for ADHD, and it is not approved. It does not mean we cannot use it. Please understand, it does not mean we cannot use it. Off-label trial, yes, we can use. Okay. So this was, so many questions will be solved from this small table which we are making. Okay. So these were the stimulants, right? Please remember the drug of choice, very important, and important side effects. So all of them will have a side effect of, other than this, insomnia will be there, right? Insomnia will be as a side effect. Okay. Next is non-stimulants. In the non-stimulant, the first is atomoxetine. Atomoxetine. It is a norepinephrine reuptake inhibitor. Norepinephrine reuptake inhibitor. Right? So it's a norepinephrine reuptake inhibitor. One important serious side effect of this you should remember is it can increase suicidal thoughts. It can increase suicidal thoughts. So a child having depression with ADHD, you should avoid atomoxetine because it can increase suicidal thoughts. Right? Next is alpha-2 agonist. Alpha agonist. Any alpha agonist, presynaptic alpha agonist? Any presynaptic, you can just write alpha agonist. Any presynaptic alpha agonist you can think of starting with C. Very good. Clonidine. Clonidine. Any other starting with G? Guanfacine. Very good. Clonidine, in fact, is a very, very useful drug in many conditions in psychiatry. Okay, so clonidine and guanfacine, right? Clonidine is also useful in tics. Okay, so it is also useful in tics. So when a child with ADHD and tics come to us, we can use any of these non-stimulants, but clonidine may be preferred because it is also used in the treatment of tics, right? So again, very useful. Second is, one of them, what is clonidine? If I ask you, where in pharma you have studied clonidine? Tell me. Which system you have this? Okay, I'll ask you system. Which system clonidine? Heart, cardiovascular? Related to what it was doing? It was decreasing the blood pressure. It's a hypotensive agent, right? It's a so what is one of the side effects would be hypotension. It can cause hypotension. Second is this drug also causes sedation. This drug causes sedation, right? So this drug causes sedation. So it will be, so suppose parents say, doctor, most of the symptoms are in the evening. Evening is very difficult for us to control. So you cannot give stimulants because stimulants will cause insomnia. So you may use in the evening. Okay, it may be used in the evening because it will also cause sedation. Okay. Right? Now, last is, there is one more use of clonidine we will discuss in fact, two more uses of clonidine we will discuss when we discuss substance and we will discuss other, disorders. So I'll tell you, what is bupropion we have discussed yesterday. It's a, first tell me what is the category of drug bupropion? Very good. It's a NDR. Very good. Remember when we were discussing depression, I told you one was SSRI, SNRI, this is NDR, right? And so it's a antidepressant. So it's an antidepressant which is, so it is useful in depression. One uses it is used in depression. Second uses it is used in ADHD. We'll discuss one more use, although we've discussed this in smoking cessation. We'll discuss. So again, you may be asked, so a child is having depression with ADHD. Which drug you may prefer? Bupropion, because it is also an antidepressant, and which you should avoid? Depression, atomoxetine. Very good. Again, same as the first table, first two drugs are FDA approved, is not approved. Okay, so you can just remember like this. So again, this small table, but will give you many questions. Okay, yes, and it's an antidepressant. Good. Right? So please put a hashtag, please revise. Two types of questions are asked from this ADHD. One is the symptoms, you have to make a diagnosis. Second, they may ask the treatment. Once again, also in the treatment, we can use therapy. Therapy can also be used. We can use, there are many therapies, interventions. Occupational therapy can be used. Psychotherapy, everything, all those things can also be added in the treatment. Tell me, can adults have ADHD? Can adults? Okay, how? How adults will have ADHD? I said the onset occurs before 12 years. So if yes, adults, you are right, adults can have ADHD. What does this mean? This means that the adult who is having ADHD, the symptoms started when he was less than 12 years and they continue now even in the adulthood. Otherwise, many of the patient children, the symptoms with age, they decrease. With age, symptoms decrease, but yes, sometimes they can continue even in the adulthood. Then we call it as adult ADHD. Okay, be very careful. In fact, many of the adults with ADHD will come and ask you, doctor, please give me these drugs. Please give me these drugs, because these drugs, increase, sometimes your potential, yes, your attention, your potential also. So you should be very careful. And amphetamine, we know, is also addictive, right? So adults can also have ADHD. Please remember this. Okay. So this was about ADHD. Everyone has written this table, right? Great. So let us come to the second important disorder. Again, recently 2019 question was asked. A very simple question was asked from this. So second topic is autism spectrum disorder. This is again a new term. This is again a new term in DSM-5. So just like DSM-5 did OC and related disorder, they clubbed all the disorders under that. Similarly, they make an umbrella term, autism spectrum disorder, put everything here. Whatever disorders are looking similar, let's keep them together. Okay. So this was also known as pervasive developmental disorder. Okay, so sometimes you may find this term in the question. It is the same, pervasive developmental disorder. Right? This is also a neurodevelopmental disorder. Okay. Neurodevelopmental disorder. Okay. So that means it is again has neurological basis. Okay, the child is not behaving intentionally making out these symptoms. Okay. Again, just like in ADHD there were two symptoms, similarly here also there are two symptoms. Okay, so there are also two symptoms. Two symptoms ADHD, two symptom autism spectrum. What are the two symptoms? First symptom is that there is deficit or problems in social communication. Okay, so their social skills are very poor. Okay, so there is poor social behavior, poor social communication. Okay, so when we talk to each other, talk to people around, we need that social communication. Okay, so they have that very awkward behavior. They have very awkward behavior. Okay, you find very strange. When you talk to them, they're looking here and there. They may just look down. They're not talking to you normally. They may have a poor eye contact. Okay. When we talk to each other, we maintain an eye contact. But these children may have very poor eye contact. Okay. So there is deficit in social communication. Right? So one is this symptom. Second symptom is that they have certain behaviors they repeat again and again. They have a very repetitive or restricted. Restricted means that they will do only limited activities. They just do some activities and they keep on repeating those behaviors. So they have a very restrictive and repetitive pattern of behavior. So their activities are very rigid. Okay. So very rigid schedule they have. They will wake up every day 6 o'clock in the morning. Every day I want a paratha in my breakfast. I will study only on this table. I will sit only at this position. So they have very restricted and very rigid activity schedule. Okay. They play with toys. They play with toys in a very ritualistic manner. Very ritualistic. So this boy who is having autism spectrum, to give him a toy car, he just pull out the tire and play with the tire. Any car you give him, he will play the same man. So they have a very ritualistic pattern of playing with toys. Give this girl with autism a doll, she'll pluck out the head and just play with the head. Any doll you give, she'll play with the same man. Okay, so they will play in a very routine manner. Okay. Change is very frightening for them. Change is frightening for them. Okay, you tell this child, we are changing your room. Oh my God, we will make a chaos. You say we are changing the home, we will make your life hell. I don't want to change. I will not change. So any change is very frightening to them. They want to continue with the pattern of things which they are doing. Okay, so you may go in a classroom, child is just sitting in the corner, not interacting with anyone, just doing his own thing. Classically, you will find such children with autism. Okay, so these are two very important symptoms of autism. Both symptoms are clear to you? Very important. There was one more symptom, there was a third symptom which now has been removed. So there was one more symptom which now no longer is in the diagnosis. What was that symptom? Language impairment. Language impairment or language deficit. Okay. So problems in the language was there earlier, but please remember this is now being removed. So there are only two symptoms, but still you should know, okay, that there was one more symptom. So now we say that yes, these children may have language problem, but it is not required to make the diagnosis. Okay, the first two symptoms are enough, adequate. Okay. Anybody seen this series? Good doctor, very good. More common one if you've seen this. Have you seen this? Anyone? Seen this? Good. So you can see he has a very awkward behavior with talking to people. This is his spot. He will sit here only. Nobody can sit here. Even when he has to go to the washroom, he has a fixed time. Only at that time I will go. Okay, everything he does is very ritualistic. Classical example of someone having autism-like features. Okay, so this is autism. Now please understand, I told you that the autism spectrum disorder is an umbrella term. Okay, autism spectrum disorder. So there are many disorders which are kept under this. So I will name those disorders to you, and I will briefly discuss one because it may come as an exam question. Okay, so there are many disorders. First is autistic disorder or simply autism. Autistic disorder or simply autism. Okay. It is more common in boys or girls? Very good. Much more common in boys than girls. Generally has onset before 3 years. Sometimes even in an infant you are able to see autistic traits. A child, an infant less than 1 year, social smile is missing. Generally when you try to pick up a child, he will put this posture that he wants to be picked up, isn't it? But a child with autism will not make such posture. Okay, not make such gesture. So even in 1 year age, less than 1 year also sometimes we are able to diagnose autism. Okay. Most common genetic disorder associated with autism, anyone? No, other than down you can know anything with X. Yes, fragile X. Very good. Fragile X syndrome. Okay. So one is autism. So this simple question they'd ask. I'll show you that question. 6-year-old child not interacting with much with peers around diagnosis. Simple question was there. Answer was autism. Right. Second is this. Everyone has written this. Right. Second, this I want you to remember. Rett syndrome. This is important. Put a hashtag over this. Put a hashtag over this. This I want you to remember. Okay, I'll show you. Yeah, this is autism or autistic disorder. Rett syndrome, I want you to remember few clinical things about this. So all these disorders which I am discussing under autism spectrum, 2 symptoms are common. What were the 2 symptoms? Deficit in social communication and repetitive restrictive behavior. Right. Onset is before. Yeah, right. So this before 3 years. Very good. This before. Please remember this. Okay. So next is Rett syndrome. Rett syndrome is more common in boys or girls? Very good. This is one exception I want you to remember. Much more common in girls than boys. In fact, initial days it was thought that boys don't have Rett syndrome. But now we know that even boys can have Rett syndrome. Okay. So 2 symptoms are common. Problems in social communication, repetitive behavior. What other symptoms are there in Rett syndrome? This is very important. Many times this has been asked in question, and you can expect one question from this. Especially when they are asking clinical question, this is a very good question which will become. So what happens in Rett syndrome is the first 5 months of birth, first 5 months after birth are absolutely normal. Everything is normal, no problem. You will never be able to think that this child who is after 5 months there is any problem with this child. No problem. Problem starts from 6 months to 2 years. Problem starts from 6 months to 2 years. Then is the problem which is starting. Okay. So basically from 6 months to 2 years there is a progressive encephalopathy. Right. So there is progressive encephalopathy. Okay. Problem starts from 6 months to 2 years. Okay. So what type of problems occur? Few things I want you to remember here. First is, so by the 5 months, whatever movements, hand movements the child has acquired, there will be loss of those hand movements, loss of purposeful hand movements. So there will be some non-purposeful movements. Remember we discussed what were non-purposeful movements repeated known as? Yes, what were those? So those were mannerism, those are purposeful. This movement, remember what is this? In catatonia we had discussed what were these movements? Stereotypy, very good. So they have stereotypic movement. Okay. And one very important hand movement is which they give in the question. Hand, write it, highlight this in your note. Hand wringing movement. Hand wringing movement. Stereotypic movements like hand wringing. Please highlight this in your notes. This has been asked many times in the exam. Hand wringing movements. Okay. So again, very important. So what are hand wringing movements? Basically, these are stereotypic movements which occur in the midline of the body. So movements like this, any movement which is there in the midline of the body. So this is hand wringing movement. Okay. So such movements will be classically seen in the child. Second is loss of acquired speech. Whatever small simple babbling the child has acquired by 5 months, those will go out. So as if the child is regressing. Okay, as if the child is regressing, right? And last and very important point, the head circumference growth. So so the head circumference growth, it deaccelerates. So the head circumference now will go on decreasing as compared to the body. It's not increasing as with respect to the other body organs. What will you find clinically? Anyone from pediatrics can tell me what will you find? Microcephaly. Very good. Microcephaly. Again, this is very important. These 2 points are the reason of telling you discussing Rett syndrome in detail is this. They may ask you a question, a girl is having symptoms of poor social communication, repetitive behavior. She has lost the hand movements. She is doing some repeated movements. Her head circumference is also decreasing. Diagnosis. What is the diagnosis? Rett syndrome. Very, very important. So please remember this. This is you can expect this question to come. So this is, please put a hashtag over this. It's a very, very important question which can be asked. Have you seen Burfi? Yes. Priyanka Chopra is a female. A lot of hand wringing, if you see again, a lot of repetitive movements she is doing. She has poor social communication, repetitive behavior. Of course, they have not shown the microcephaly, but it seems to be most likely she is suffering from Rett syndrome. She is suffering from Rett syndrome, right? Next is, third is childhood disintegrative disorder. Childhood disintegrative disorder, also known as Ehlers syndrome. Ehlers syndrome. Okay. Again, this is more common in boys than girls. Okay, if I ask you, let's write it down, then I'll ask you. So there was once a question in some exam related to Rett syndrome. Okay. Yes, they may be, mentally, again, many of them may have mental retardation, but it's not that all of them will be mentally unstable. I'm not saying that there is mental retardation. Many of them may have mental retardation, right? But it's not that always they will be mentally unstable, right? Now, one question was asked in an exam about Rett syndrome. Tell me the false statement. One statement was, in Rett syndrome, microcephaly is present at birth. Is it true or false? Please remember this. Okay, so yes, it is false. Okay, so this is, I will not discuss in detail the 2 common symptoms of this as we have already discussed. Last is Asperger's syndrome. Again, more common in boys than girls. Here they have abnormal, in social communication, there is 2 types of communication. One is verbal and one is non-verbal. Non-verbal means through gestures. Here they have abnormal non-verbal communication. Okay. So they will never be able to cheat in the exam. Isn't it? For doing that in exam, you need a lot of, non-verbal communication, lot of gestures you require. Okay. And please remember I told you earlier that what was the third symptom, which is not now the diagnostic, language deficit. But these patients never had language impairment. So these never had any language impairment from the beginning. So there is no language impairment. No language impairment. Okay. So there is no language impairment, right? Seen this movie? My name is Khan. I'm not a terrorist. SRK is a boy, is a male, is a somewhat common in boys. He's singing in the movie, so his language impairment is not there. Suffering from Asperger's. Okay. Social deficit communication is there, repetitive behavior is there. So he's suffering from Asperger's. Okay. Asperger's. Right? So this was about autism. Again, treatment, we don't have any, treatment. Of course, main line of treatment for all these disorders is therapy. Okay, therapy, behavior therapy, occupational therapy. Okay. Drugs are only used for symptoms. Drugs are used only for symptom reduction. Like for example, if the child is very aggressive, we can use low doses of antipsychotic. Child is having depression, anxiety, we can use those drugs. Okay. So main line of mainstay of treatment is therapy. Okay. For all the autism spectrum disorder. Okay. So again, autism question has been recently asked. Very simple questions have been asked on this topic. Please remember. Next topic, again, 2020 question. Third is specific learning disorder. Seen this movie? Child was suffering from SLD. Specific learning disorder. Specific learning disorder. So basically from the name itself you can see there is problem in certain specific areas of learning. Specific learning. Other things are normal, but finding problem in, so these children will come with academic problems. Okay, or they will come with poor academic skills. Parents will say, doctor, everything is fine, he's a very good child. I don't know why the teachers are complaining. Okay, many the time, the children, when the child is brought to us, many a time it is the complaints of the school for which they send the child for assessment. Because the child is not able to cope up with certain areas of learning. Okay, so specific learning disorder. So if you can see in the movie, the father thinks that he is doing mischief. But we have to make him understand that this is also one neurodevelopmental disorder. Typical father, typical Indian father has been shown in the movie. And when Amir Khan shows in the Chinese box and asks him to read, this is what is actually happening to the patient. He's not able to understand what is it, right? So specific learning disorder, SLD, right? Sometimes known as specific learning disability, same thing. Okay, disorder or disability, right? So there are many types. Just let us understand, because one specific question was asked. Yes, last slide. Okay, so we are having problems in learning. No social communication problem, no problems in behavior. Okay, no hyperactivity. Having problems in learning. Okay. So one is SLD with impairment in reading, also known as, anyone? Very good. Dyslexia. Very good. Dyslexia. Okay. So here what will be happening? These children will have poor reading skills. Poor reading skills. Okay. So they don't know this is D or this is B, confusion. This is 7, this is 7, confusion. So they are not able to comprehend letters, words, so they will have difficulty in reading. Okay. So they have reading difficulty. Ask them to read anything, they will have problems. Okay. Sometimes they will do everything else. The mother will say, doctor, in written exam he comes first. I don't know why. When teachers take oral test, they say he is very poor in oral test. Okay. So they are also astonished how is it happening. So sometimes child is having only problem in the reading skills, in the reading department. Okay. Second is SLD with impairment in writing. So here they have problems in writing. Okay. So you ask them to write phone. On one page you may find this as the spelling. On another page you find this as the spelling. So there will be a lot of spelling mistakes. So just ask the parents to bring the notebook. You will be able to understand, oh, there is some problem. They will have very poor handwriting. Okay. So they have impairment in writing. Okay. And the last is SLD with impairment in mathematics. Okay. So they have problem in mathematics. So they don't know this is addition or this is addition. This is multiplication or this is multiplication. Okay, you ask the child. So what we do when we examine the child, we give simple calculations. The child is not able to do it. Okay, so they have problems in mathematics. Okay, so these are important types. Also, there is one more when it can be. Fourth is when it can be mixed. It can be a combination. Reading and writing, reading, mathematics, or even all the above. Child is having or all the above. So in the movie, it seems the child has mixed. Okay, the child has mixed SLD. Now please understand that SLD can vary on severity. If it is very severe, the child will be brought to you in the elementary classes. Even in nursery, the child will be brought to you. So he is not able to do as his peers. Sometimes when it is not very severe, the child is able to pass the initial classes. Like mathematics, he is able to do calculation. But when it goes to cos theta, tan theta, it becomes difficult for him. Okay, so many times before 10th class, these children are brought to us for assessment. And in CBSE, a lot of benefits may be given. If the child is diagnosed with SLD, they may be given half an hour extra. Someone else can write the exams for them. They will just sit and tell. So many such benefits may be given for the child. In fact, many doctors I know are suffering from SLD. True, but since we have an MCQ based exam, so it becomes easy. They will say, sir, it would have been a written exam, we would not have been able to clear. Okay, so this may be seen. Many actors, Abhishek Bachchan, you would know, was suffering from. So many people may be suffering from SLD. It's not the end of the road. They can excel in other classes. Yeah, they can. So they are good in other skills. Okay. So last topic here is. So this question was asked in 2020 on SLD. They said a child is good in social communication. Is in interaction with others is good. In all the other things he is doing fine, but his mathematics skill is poor. Diagnosis. SLD. Simple question was asked in 2020. Very, very important topic. Next is mental retardation. Okay. Treatment, yes, treatment again we use therapy. A lot of therapies are done, special sessions are taken, one-on-one sessions are taken, as you could see even in the movie. Many times, people are able to overcome, but sometimes they may be able to overcome only some part. Okay. So again, treatment is therapy. Okay. Drugs only if there is any symptom. Okay. Right. So can anybody tell me what is the new name of mental retardation in DSM-5, very important question. They may ask you this question because this question is there for so many times. You may ultimately expect this question. Anyone? Very good. Intellectual disability. Very good. Disability. Very important. Okay. Very important. Intellectual disability. Highlight this in your note. Okay. So they say calling someone retarded is not good. Ethically, it's not a good term. So they say we will use the term intellectual disability now. Okay. So basically, what is happening is there is problems in intellectual functioning. Okay. So intellectual functioning like reasoning. Okay. Or learning. So there is problem in intellectual functioning. Very good. Yes, it is intellectual disability. Yes. Intellectual functioning, problems in intellectual functioning and problem in adaptive behavior. Adaptive behavior is the behavior which is required to do day-to-day things. Social behavior, you can say. Okay. Or the practical skills. So the social or the practical skills required for us in our day-to-day lives, those are missing. Those are problematic. So intellectual functioning is absent or problematic and adaptive behavior. Okay, and the onset of mental retardation or intellectual disability should be before 18 years. Okay. Should be before. So there may be many causes. When you will read, there will be many causes. Sometimes it is, in the antenatal, period, mother got infection because of hypothyroidism. Even later on, because of some or the other infection or some or the other cause, endocrine cause, hormonal cause, any such cause, child can have mental retardation. So onset should occur before the age of 18 years. Okay, before the age of 18 years. One important point about mental retardation which you should know, and this has been asked in the question also. What is IQ? What is IQ? Very good. It is intelligence. Very good. Intelligence quotient. This question was asked once. Intelligence quotient. IQ is intelligence quotient. How? So question was how to calculate IQ. How do we calculate? Very good. The mental age upon chronological age. Mental age upon chronological age into 100. This was asked in the exam. This was asked in the exam. So IQ is mental age upon chronological age into 100. Okay. Please remember one important point. Chronological age is never more than 15 years. You never have to take chronological age as more than 15 years in the formula. What is mental age? Mental age means that what is the state of the mind of the child. Okay, so this we calculate. This is calculated by using certain tests. So we have intelligence tests. So we perform those tests and we get a mental age. Chronological age is the age because by birth we calculate, date of birth. So chronological age is the age we calculate from date of birth. Okay. Mental age is calculated by the test. Now, let me ask you. So we have a child who is 10 years of age. So child is 10 years of age. We are calculating IQ. Let us say we got his mental age as of a 5-year-old. So he's 10 years, but his mental age is as of a 5-year-old person. Right? What will be chronological age? 10, yes, into 100. Another child, 17-year-old child, we calculating IQ, we calculated his mental age came out to be 7. What is the chronological age?
15.
Very good, not 17. Because denominator will be never more than 15. Maximum I will keep it as 15. Okay, so please remember this. Okay, so this question has been asked. I hope everyone has understood. Again, this was a 2020 question. 2 questions from this topic they had asked. One was on SLD. Second was again we always discuss this table, which I am going to discuss, and one question was asked from this table. Right? Everyone has written this. Good. So based on the IQ. So again, this table is very important. So always we discuss, and this time they ask a question. Such a direct question was asked. I will tell you what was the question. So before this, let me tell you what's a normal IQ. What is the normal range? 90 to 109. It's a normal range. Okay. So normal range of IQ is 90 to 109. Borderline. Very good. Borderline IQ or borderline, you can say. Child having borderline intelligence is 70 to 89. Right? Okay. Normal is 90 to 109. Borderline is 70 to 89. So what is mental retardation? Less than 70. Very good. IQ less than 70. Okay. So someone having mental retardation, his IQ is less than 70. So it can be divided on the basis of the IQ as mild MR. This table is very important. This time they actually asked a question in 2020. We discussed this finally, they are asking such simple question. It was, if you know the values, mild, moderate, severe and profound. Okay, calculation again, I'll just tell again. Mental age upon chronological age into 100. Mental age is calculated by the test. We perform some test. Suppose a 10-year-old child tests his mental age, it comes out to be 4 years. So we'll put 4. Chronological age is his age by birth. So this 10-year-old chronological age means 10. Denominator should never be more than 50. Right? So if a child is 17 years age, we will only keep the denominator as 15, not more than that. Right? Now, coming to this table again, this first column is very important. If you don't want to remember anything, do remember the first column, at least first column. Okay, so let us see according to the IQ. So for mild MR, what is the level? So it will be less than 70. So it will be 69 to 50. Okay, because less than 70 we are saying mental retardation, MR. So mild 60 to 50, 69 to 50. Then 49 to 35. Between this, it is moderate. Severe is 34 to very good 20. Okay. Less than 20, profound. Okay. Highlight this table, mark this table, very, very important. Again, I am telling you, only few data in psychiatry are there. This is one. Very, very important. Again, I am putting it as very important. The question which was asked, simple question, a child having IQ of 55, diagnosis, mild MR. Such simple direct question was asked. Okay. Now, generally we say a child with mild MR studies up to, he will be able to study up to 6th class. Okay. In India, you will see the parents say, no, doctor, he studied 10th. But you will say that the under the table method was used to pass him. Okay. So if he gives the exam by himself, the person will be able to pass the class up to 6th standard. Okay. Moderate up to 2nd. Okay, up to 2nd class he'll be able to pass. So when you're interviewing a person, you will find that there is problem in education. I will remember. So there will be problems in education. Get to know there may be some problems, right? And severe and profound, no formal education. They will not be able to study. No formal education may be given. So they will not be able to get any formal education. Okay. So their mental age would be, so if we see the mental age of child with MR, mild MR, it will be around 9 to 12 years. So person is 17 years age, but his mental age is like a 9 to 12-year-old child. Okay. So because the brain, mental retardation, the brain has not developed. Okay. Then someone with moderate mental retardation, it will be from 6 to 8 years. Okay, 6 to 8. Then severe 3 to 5 years. So even if the child is 15 years, 20 years, see his age, mental age is 3 to 5 years old. You can see how much he'll be able to handle himself. While someone who has profound MR, his mental age is less than 3 years. Even the basic things like eating, going to the washroom, all those things will also not be able to manage by the child himself. Okay, so this is again, please remember this. Again, if you have to revise, so I am telling you what are the important things. You don't want to learn anything else from stable, do learn the IQ levels. Okay, now coming to the treatment, or before that, tell me the most common genetic factor, most common genetic cause or genetic factor variable. Down syndrome. Okay, Down syndrome. Which type of dementia may be seen in Down syndrome? Down syndrome, dementia, anyone can tell me? Down syndrome, dementia, can anybody tell me? We discussed, remember, Alzheimer's dementia, remember? APPG, chromosome 21, remember? Second common cause, Fragile X syndrome. Fragile X syndrome. Okay, there are many causes. Second is Fragile X syndrome. Right? Okay. Now, in the treatment, again, there is no cure. Please remember, there is no cure. Never tell, okay, we have something which will cure the mental retardation. No, we have no cure. So, we can use certain behavior techniques to modify the behavior. We use behavior techniques. One of the important behavior techniques which we use, which you should remember, is contingency management. Contingency, this has been asked as a question. Management. So basically, we are trying to modify the behavior. We are trying to modify the behavior of the child. Okay, contingency management. So what we do is we reward a desired behavior. So suppose I ask the child, we are going to watch a movie. If you sit in the movie, he sits in the movie and does not make any disturbance, I come back home, give him a chocolate. So what I am doing is I am rewarding. So so if I tell a student, okay, if you study, I'll give you a chocolate. So you study for 2 hours. Then next day you will study again for 2 hours because you will get a chocolate. So this is increasing the desired behavior. While what we can do is we can punish the undesired behavior. Suppose this child is making a lot of noise, I can tell him that for 2 hours you will not be allowed to watch television, or you have to sit in your room for 2 hours. So this will decrease the undesired. Again, the punishment should not be harsh punishment. Please remember, it should not be harsh. Okay. So again, this has been asked as a previous MCQ. So please remember this contingency management. Okay, and sometimes we may require drugs for certain symptoms. Drugs is used only for symptomatic management, symptomatic treatment. Okay, for example, if the child is very aggressive, sometimes they may also develop delusion, hallucination, then you can use antipsychotics. Similarly, if there is anxiety, there is depression, you may use SSRI. So this will be only based on the symptoms. Okay, so this is based on the symptoms. Please remember what is contingency management. Okay. Contingency management. Again, many questions have been asked on this topic. Very, very important. Please remember. Okay, please remember this topic. Very small topic of child psychiatry, but a lot of questions have been asked. And they will ask ADHD especially. Up till now, question on ADHD are not very much asked. They will ask now because clinically it will become a very important topic. Okay. Another important topic, a very small topic, but another important topic is substance use disorder. Substance use disorder. Okay. Now, substance use, this term substance use is used in DSM-5 and the ICD-10 use the term dependence. It is one of the same thing, you can remember. Okay, ICD-10 uses this term, dependence, substance dependence. It's one of the same thing. Okay. Now, there are two brothers, Mukesh and Suresh. Any Suresh in the class? Good. Good. Okay, so there are two brothers, 40 years of age. This Mukesh is the Mukesh which says, you know, I was smoking cigarette, what happened? You know, before the movie you will find Mukesh. Remember, recognize him? Okay. So, both are 40 years of age. Both started drinking alcohol when they were 20 years of age. So, both started drinking alcohol. Okay, they started with 1 peg of alcohol. How much is 1 peg of alcohol? Anyone? How much? 30. Very good. 30. They started with last 60. Yes, of course. Patiala will be 90. Yeah, 120. Then over the course of time, Mukesh would started consuming 3 to 4 pegs every day. They started in a party, but Suresh would still continue only 1 peg. That also very uncommon, you know, in parties only. Over the course of time, this Mukesh started consuming 1 quarter. How much is 1 quarter of alcohol? 1 quarter. 180 ml. But yes, it's good if you don't know. It's a good thing. Don't worry. Be happy if you don't know it. In fact, it's a good thing. Okay. And now when they are 40 years of age, Mukesh is consuming 1 bottle. 1 bottle. How much is 1 bottle? 750 ml. Right, Suresh? Yeah, it may vary in Russia. I'm not sure about the Russia volume. Suresh still consumes 1 to 2 peg only 6 to 5, every 5 to 6 months. Tell me, who do you think is having problem? Okay, Suresh may be having some other problem, but yes, alcohol problem or substance problem is with Mukesh. So please understand, all of people who consume substance don't have disorder, substance use disorder. This was the reason of telling you. Okay, so Mukesh says, doctor, you know, I have this. So some important terms which you should remember is, Mukesh says, doctor, I have this craving, strong urge to consume substance. Doctor, I get this strong urge to consume substance. Okay. 3 to 6, you can say 3 to 5, 3 to 6. Okay. Strong urge to consume. Okay. Then Mukesh says, doctor, when I stop or reduce my amount, I am consuming 750 ml every day. When I stop or decrease the amount, I develop certain symptoms. We will discuss every substance has different withdrawal symptoms. So you can understand what is withdrawal. We're withdrawing that substance from the body and body is producing some symptoms. Okay. So he says, doctor, when suppose I don't get alcohol in a day, I develop these things. What are these? Tremors. Okay. I develop symptoms. Okay. So these are withdrawal symptoms. And he said, when I started with 1 peg, after some time I didn't get the same effect with 1 peg. I increased it. Then after 1 quarter, I didn't get the same effect. I increased it. So this is what is development of tolerance. Increase amount is required to get the same effects. So he said, now 1 peg of alcohol does not give me that effect. Okay, so I have to increase. Now please understand, we say that if 100 people start consuming alcohol, not everyone will become substance use disorder, alcohol use disorder. 10 to 15% only. Okay, so if someone is in the 10 to 15% age, he should stop. Now you'll see that some people will just, drink, occasionally, in parties, but some will not be able to control. Okay, so these are some important terms related with substance use disorder. Let us discuss some important controversies and then we'll discuss individual disorders, most common. Which is the most common substance used in India? Very good. It is tobacco. More than alcohol. And in the world, if I ask you, it is yes. It is alcohol more than tobacco. You can find India, bidi, hookah, chewable tobacco, gutka. It's so common. So in India, tobacco is the most common. Okay. The question which has been asked multiple times is this: tobacco, is it legal or illegal? Legal. There are government approved shops. Alcohol is legal or illegal? Legal. There are government approved thekas. Come will give you alcohol. When there was lockdown, they opened alcohol. The alcohol addiction people were going saying, I am going to protect the economy. Let me go out. I will purchase alcohol. I will preserve the economy. That was not a good approach for the patients. Although the economy might have been stabilized, but many patients' life were in danger. Okay, so most common illicit. If I ask you illicit means illegal. Very good. So if I ask you what is the most common illicit substance in India? Very good. Cannabis, in Shivratri, what is someone else? Such commonly available. Ganja, you find plants, there are people consuming from that, very common. And in the world, foods, very good. So in both India and the world, it is cannabis. The question which was asked, they didn't ask about the most common illicit substance. They asked which of the following substances most common. Options were cannabis, cocaine, amphetamine, LSD. Yes, so answer becomes cannabis. Okay, so this is very, very important. This has been asked. Some books may give some wrong answer. Okay, so this, let me just see if I missed anything. Okay. So everyone is now got this again. Simple questions may come, they are coming. Please remember. Let's come to the first substance, alcohol. Okay. Please remember again get settled down. I want to finish as early as possible. Okay. But we also don't want to miss anything. Right? Yeah, I'll tell. What is cannabis? Various forms are there. Don't worry, it occurs. This is a common mistake we make. We'll discuss. Now, please understand. Please come back to the class. Alcohol, 2 questions per exam. 2 questions from this simple alcohol topic are coming. Every time, 1 to 2 questions. Last 3 to 4 exam. There is no exam in which alcohol question was not there. Let's settle down again. Let's settle down. We'll discuss other things after the class, definitely. Okay. So, alcohol, what is there in alcohol? Can anybody tell me? Beverage alcohol, what is there? Beer. It is ethanol, very good. Ethanol. Alcohol. Remember ethanol, you must have studied chemistry. Ethanol. C2H5OH. They may ask you the formula also. Okay, ethanol. Okay. So this Mukesh who is consuming alcohol. Okay. So Mukesh who is consuming, everyone has written this. Mukesh is consuming alcohol 1 bottle every day. Family member is now being a lot in trouble because of him. They say now he does not stop, we will stop alcohol. What we will do? We will put him in the room, lock him from outside. Okay, so Mukesh is in the room. So what is the family done? They've suddenly stopped the alcohol. What will develop? Withdrawal. Okay, this is very, very important. Questions have been asked. Question have been asked on the symptoms and on the treatment of alcohol. Alcohol is very, very important. Again, I'll show you one question even in your 2020 exam. Okay, question on alcohol have been asked, very common. So alcohol withdrawal. So this Mukesh, so basically withdrawal symptoms develop depending on the severity and depending on the time. Okay, so when he's in the room after 6 to 8 hours, so that means time after stopping or decreasing alcohol. So we are discussing time duration after stopping or decreasing the alcohol, right? Okay, so within 6 to 8 hours from the window, he's telling the family members, please get me out. This is happening to me, please get me out. What is this? Tremors. So the first symptom is tremor. This was a question which was asked this year. The question we were getting two sets of symptoms. One symptom was which is the most common symptom, or some students were saying which is the first symptom to develop. In both the cases, it is tremors. It is also the most common symptom. So this simple question was asked. Okay, from recall, what we could get was some were saying which is the most common, or some were saying which is the first symptom to develop. Answer is this. So, but family members say no, they are adamant. We will not get you out. Till the time your alcohol stops, we will not get you out. So, after 8 to 12 hours, yes, he started talking as if there is someone in the room. He's talking to someone. So, family members, yes. So, what develop? Hallucination. Perceptual disorders. Or you can write hallucination as hallucinations. Okay. Auditory hallucination more common than visual hallucinations. Okay. Although any hallucination can occur, auditory more than visual. Okay. So you can see even in withdrawal also we are getting hallucination. So alcohol hallucination are there in psychotic disorder. Here also they can, right? Family says no, we will not get you out. So now 12 to 24 hours have passed. They are hearing no noise from the room. They just peep out from the window and they see he's lying down on the floor. His body is moving like this. Eyes are upward, tongue wide, urinary fecal incontinence. He's having these sudden jerky movements. What is this? Yes. So finally he has developed seizures. Okay. Finally he has developed seizures. Right? What kind of seizures are these? Are these focal seizures or generalized seizures? Of course. So alcohol, the entire brain is devoid of alcohol, isn't it? So it will be generalized tonic-clonic seizures. Okay, GTCS. And these are also known as rum fits. Okay, fits because of rum fits. Generalized tonic-clonic seizures. There is a tonic phase and there is a clonic phase. Okay, tonic-clonic seizures. Okay, GTCS. Family members are worried now. They say, okay, let's take him to the hospital, but the nearest hospital is 24 hours away. Okay, so they put him in the car, they reach the hospital. By the time they reach the hospital, so by 48 to 72 hours have passed, they say to the doctor, he's saying that, we are at home. He's saying that I am his friend, but sir, I am his father. What is this phenomena? He is not identifying person, place, time. He is disoriented. What is the symptom? Impairment of consciousness. What it will be? Delirium tremens. Remember I told you delirium tremens we will discuss? Delirium tremens, and this is an emergency. Delirium tremens is an emergency. It can lead to even death if untreated. Delirium tremens, it's an emergency, can lead to death of the patient. Again, this is very, very important. Very important. Please, alcohol, don't miss anything. So I will going to discuss. CNS has been done in medicine. CNS is over. Okay. Right. So I will discuss some other. So this is the withdrawal phase. Everyone understood? Withdrawal phase. Okay, we will treat this patient. Before coming to the treatment, I also want you to, we'll also want to discuss certain neurocognitive disorders because of alcohol. In the past 3 exams, twice they have asked question on this topic. So each time we discuss, now they're asking, such simple question. I'll tell you what was the question. This year, I think there was a clinical question, and last year there was one direct question. Okay. So what I'm telling you is, Mukesh is consuming alcohol for a long time. So this can also affect his CNS. Okay. So it is leading to certain neurocognitive symptoms. So alcohol-induced neurocognitive disorder. Okay. There are 2 disorders which we discussed today. Wernicke's encephalopathy, Korsakoff psychosis or Korsakoff syndrome, also known as psychosis. Although there is no psychotic symptom, the term is Wernicke's encephalopathy and Korsakoff syndrome. Can anybody tell me other neurocognitive disorder because of alcohol we have discussed already? Remember when I told you that 15% of the cases of dementia are reversible? In that, I told you the last that alcohol can also lead to dementia, isn't it? So it can also lead to dementia. Okay. So these are the 2 important neurocognitive disorders which we are going to discuss. So I'm making a table to make things simple. It will be very easy for you to remember this way. Let's discuss them one by one. Let's discuss first Wernicke's. So how is the onset of Wernicke's? Can anybody tell me? How is the onset of Wernicke's? Is it sudden or is it gradual? It is sudden or acute onset. Within few hours, the symptoms will develop. It is sudden in onset. Okay. Wernicke's encephalopathy. Okay. Then, what are the symptoms? There is an acronym, mnemonic to remember. GOA. Very good. This was the question. They had asked clinical symptoms of Wernicke's this time. G is global confusion. So it may appear like delirium, but for delirium to occur, delirium tremens, there will be other withdrawal symptoms also, isn't it? But here only confusion is there. Okay, person is appearing confused. What is O? Ophthalmoplegia. There is deviation of the eyes. So the eyes will be suddenly deviated like this. So this way or that way. Lateral rectus is most likely called so this way. So the person is not able to move the eyes. Deviation of the eyes. Ophthalmoplegia. And he is constantly following, not able to move properly. It is called, yes, ataxia. Okay? Ataxia. So these are the important symptoms. This was the question which was asked in 2020. Pause. A direct question was there. Neurocognitive disorders because of alcohol is caused by. What is the cause? Deficiency of, very good, deficiency of vitamin B1 or thiamine. This is again very, very important. Why thiamine deficiency is occurring in alcoholic patients? Can anybody tell me? So alcohol patient, have you seen alcohol patients' nutrition? It just requires some salad and alcohol, nothing else, or maybe some few other things. Their nutrition is very poor. Also, alcohol is a gut irritant. It decreases the absorption of nutrients. Okay, so it decreases vitamin B1 or thiamine in the blood. Okay, what is the treatment? So what is missing in the body? Thiamine. What do we do? Thiamine. Treatment is thiamine. Initially, we may give IV or IM, then we can shift to oral. Okay, so thiamine. Treatment is you have to give thiamine. Tell me, is this condition reversible or irreversible? Very good. It is reversible. So if you treat the person, the symptoms will go away. It is reversible. Okay. So please write it again twice. They have asked question from Wernicke's encephalopathy. in the past 3 exams. One question was on B1. Second, this time they asked question on the symptoms. So twice, so such small topic and they are asking so many questions. Next is Korsakoff syndrome or Korsakoff psychosis. Tell me, let's compare. Is it sudden or is it insidious? It's a gradual or insidious onset. Yes, slowly the symptoms will develop. One symptom I have already discussed. Can anybody tell me? Remember when I was talking of organic amnestic syndrome? I told you only one thing to remember Korsakoff. So amnesia, loss of memory. And anterograde more than retrograde amnesia. Anterograde more than retrograde amnesia. Right? So anterograde means, so I am forgetting things from now, maybe from now to the next morning, I forget things in the forward time. Retrograde means I have forgotten things of the past days. Okay. So both are seen, anterograde more than retrograde. One very important symptom which has been asked in many times in the question, although they are not asked related to Korsakoff, but this symptom they have asked a lot. What is that symptom? Confabulation. So they have asked question on this term. What is confabulation? What is filling up of memory gaps? So filling up of memory gaps with false stories. So this person is not able to remember things. So he was drinking alcohol yesterday with his friends. So wife asked, what were you doing yesterday? He's forgotten, does not remember. He just makes some fabricated stories. This is confabulation. They have asked question on confabulation. Please remember this. Question on confabulation has been asked. Okay. Again, what is the cause? Cause we have already written. Vitamin B1 deficiency. Okay, cause we have already written. Treatment, what is the treatment? Thiamine, very good. Treatment remains the same. Here, thiamine we may have to continue for months together. We may have to continue thiamine for months together. Okay. Is it reversible or irreversible? It is irreversible. Some symptoms may improve, but in totality, it will never be completely reversible. It may be partially reversible. So it is irreversible. Please remember this, very, very important. We may be discussing again in medicine also, but I have discussed here because many questions have been asked on this. Okay, so we have discussed in a table manner. Okay, everyone has written this. It's very, very important. Let's come to the treatment. Let's come to the treatment. So this Mukesh has come to us with withdrawal symptoms. So whenever we treat, we will be discussing two phases. One is Mukesh, when he has come to us now, he is in the withdrawal state. Doctor, he's having tremors, he's having hallucinations, seizures, he's in delirium. Please remember, not all the patient will have all the symptoms. Only severe alcohol addiction patient will have severe symptoms. Some may just have these tremors only. Okay, so this will be depending on the amount of alcohol they consume, right? So detoxification is basically we treat for withdrawal symptoms. First is detoxification phase. So we treat the withdrawal. So for withdrawal symptoms, okay, can anybody tell me drug of choice? No, benzodiazepines. Yes, benzodiazepines. Well, then benzodiazepines. Can anybody tell me? Benzodiazepines. Okay. Can anybody tell me alcohol is a CNS depressant or stimulant? How many is stimulant? It may give you an initial euphoria, but ultimately it's a depressant. it dulls the muscles. It's a depressant. So when the body is devoid of a depressant, how can you understand why the withdrawal symptoms are occurring? Body is getting everyday, brain is everyday getting, so this is inattention. When our focus it. Okay. So our brain is getting a depressant, and suddenly I don't give, remove the depressant. The body goes in an excited state. Okay, so that is why you can see all those symptoms, very excited symptoms are there, right? So benzodiazepines are the drug of choice, very important. 3 important benzodiazepines which we use: lorazepam, diazepam, fluordiazepoxide. CNS done in pharma? Yeah. Okay, lorazepam. So lorazepam is long acting, short acting. Very good, short acting. Diazepam, fluordiazepoxide, they are longer acting. Okay, short acting, you can write short acting and long acting. Okay, short acting means for just a few hours the effect will be there, then it will go out. Okay. Lorazepam is available as IV, IM, oral. So you can give lorazepam as IV route, IM route, or orally also. Okay. Diazepam. Anybody with IV? Yes, you can give IM also. Oral tablets are also available. Okay. All these 3 routes you can give. Can anybody tell me about fluordiazepoxide? It is oral. It is only oral. Okay. Only oral route is available. Okay. Now, few important points I want you to remember here, which will be very useful in your exams. One is, suppose a patient comes to us, let us say his liver function is compromised, or let us say we have sent the LFT, results are awaited. Of course, in alcohol, liver is affected, alcohol liver disease is there many a times, isn't it? So if the question says that liver is compromised or LFT report is awaited, okay, so which is the drug you will prefer? L for lorazepam, L for liver safe. Okay. L for lorazepam, L for liver safe. Okay. Right. Now, suppose a patient comes to us with delirium tremens. Delirium tremens is a medical emergency. In delirium tremens, it's a medical emergency, can lead to death. You will prefer a short-acting drug or a long-acting drug? Short-acting drug, I give the patient 2 hours later, again delirium comes. Then I have to again give. I prefer a longer-acting drug. And I am telling you, delirium patient is not able to control. Will he take oral pill? Which will be the drug we will use? Diazepam. D for diazepam. D for drug of choice in delirium tremens. D for diazepam, D for drug of choice in delirium tremens. Again, please remember, I am not saying other drugs cannot be used. Of course, I have also used lorazepam also. I have also sometimes used fluordiazepoxide also in delirium patient. But you have to choose one. Okay. Right. Can anybody tell me treatment of seizures? Withdrawal seizures is person is having, so withdrawal can be any type. Withdrawal seizure, what is the treatment? Will you use any anti-epileptic agents? You will. How many of you will use it? Okay, please remember, no need to use any anti-epileptic. The seizures are occurring because of withdrawal. So I am telling you withdrawal, I am giving you the drug of choice. So any withdrawal symptom, even for seizures, it is benzodiazepines. Right? Now please remember, we also, along with benzodiazepines, also add thiamine. Along with benzodiazepine, also add thiamine. Right? There was once a question. A person is having alcohol withdrawal. They have given symptom, tremors was there, there was sweating was there, and hallucination was there. Withdrawal hallucination. They had asked treatment. One option was lorazepam plus haloperidol. It's an antipsychotic. Another was lorazepam plus thiamine. Please don't get confused. Even if it is hallucinations, psychotic symptom, then also benzodiazepines are the drug of choice. Don't make that mistake. Yes, of course, if the patient is very severe, very agitated, then I may have to add antipsychotics. But standard treatment will be benzodiazepines plus thiamine. So this question has been asked. Please remember, you can expect, put a hashtag, and please, such questions are very high likely to be, expected to come. Okay. So we are discussing in detail, how questions are framed on this topic. Okay. So reason being, discussing clinical scenarios so that it sticks in our mind. Because questions are asked these days. Nowadays, they will not just ask you drug of choice, alcohol withdrawal treatment of choice. Direct question will not be there. Maintenance. So now this Mukesh, so basically what do we do is, we start with benzodiazepine high doses and gradually now I taper. I reduce the benzodiazepine every day. So by 7 to 10 days, I stop benzodiazepines. So the withdrawal phase is over. Mukesh is very happy. He says, sir, thank you very much. I want to go home. What will you say? No, I will say go home. But we want you to maintain this phase. So I want to start some treatment for maintenance. Okay. One important treatment which can be used, again it is not very commonly used, is, yes, disulfiram. Okay, disulfiram. The question which was asked in your exam was, what is the other name? It is actually a deterrent agent. So this question was asked, which of the following is a deterrent agent? This was in 2018 question on disulfiram. Also known as an anti-aversive or an aversive agent. Aversive agent. Please remember these terms. It's a deterrent agent or a aversive agent. Okay. We should know the mechanism of action. We should remember the mechanism of action. What does it inhibit? It inhibits an enzyme, aldehyde dehydrogenase. Okay. It inhibits this enzyme, aldehyde dehydrogenase. You may not write this, understand this. Alcohol in the body is metabolized to acetaldehyde, very good. Acetaldehyde is metabolized to acetic acid. Aldehyde dehydrogenase is also written as ALDH. Okay. So you should remember it inhibits this enzyme. MCQ question has been asked. Now, why it is used? Let me just give you a what is the action actually. So alcohol in the body is metabolized to acetaldehyde by the enzyme alcohol dehydrogenase. Okay. And acetaldehyde is then further metabolized to acetic acid by aldehyde dehydrogenase. What this drug is doing, it is inhibiting this enzyme. This enzyme is getting inhibited. Now see, if person is consuming alcohol who has a drug which is inhibiting this enzyme, alcohol is getting in the body, but this enzyme is inhibited, what will happen? There will be increase in the acetaldehyde, and acetaldehyde is toxic. It produces unpleasant symptoms. It produces unpleasant symptoms like headache, vomiting, nausea. Okay, sometimes even respiratory depression if very severe. Okay, so what happens is, that is why we are saying it's a deterrent agent. So it deters the person to consume alcohol. So person is consuming disulfiram, over it he consumes alcohol, body starts having these unpleasant symptoms. What is the message the body is getting? Whenever I am consuming alcohol, symptoms are so it is aversing him from taking alcohol. So this is disulfiram, but still it is slightly unethical at times, and sometimes patient can develop severe symptoms. So not that commonly used, but yes, we can use. Always use it with the consent. Otherwise, you know, in general public thing, there is one drug, you mix it in alcohol, you mix in food, give it to patient, whenever he consumes, the patient decreases his alcohol intake. Many times family members say, you know, many times quacks give these drugs. And family comes in and says, doctor, please give that drug. Never give this drug without the consent of the patient. Because he does not know he is having disulfiram. Okay, and he consumes excessive alcohol. Then what will happen? It may lead to severity of symptoms. Okay. Second is, this is very important. Many times question has been asked, anti-craving agents. Anti-craving agents. Okay. So again, patient says, this Mukesh says, doctor, I get a lot of craving. So he'll say, okay, I have some drugs which can decrease your craving. Two important drugs you should remember here. One is acamprosate. Very important. Both the names are very important. One is acamprosate. We should know the name and also the mechanism of action. Can anybody tell me the mechanism of action? It's what was the mechanism of action of memantine in dementia? NMDA antagonist. The same mechanism. NMDA antagonist. Please remember this. Okay. Second, anyone can tell me any other drug starting with N? Very good. Naltrexone. Naltrexone. What is the mechanism of action? Naltrexone. What is naltrexone? It's a mu opioid antagonist. It's a opioid antagonist, but we are also using it in alcohol. Okay, it's an opioid antagonist, but we are also using it in. So please remember these two names, acamprosate and naltrexone. Very, very important. Highlight this. So this again, this table will fetch you many questions. So this one table will fetch you many questions. Please remember this. High chances of a question coming from this table, especially in the detoxification phase. So there are two substances we will discuss in detail, then we will discuss in important terms about the other. Next, I'll take a break. Just let me finish this topic. Then we'll take a break. Okay, everyone has written this? Yes. Understood? Good. Next is opioid. What is this plant? Very good. This plant is very good. Papaver somniferum. Anybody from Rajasthan? Anybody seen this coffee plant? Very commonly grown there. There is a series, I think Shushmita Sen series. Anybody? Arya. Yeah. They are smuggling this. Afghanistan is the fight for Afghanistan is basically for this. Opium. Papaver somniferum, also known as poppy plant. Poppy plant. Very costly. Very, very costly. Sometimes 1 gram, 2 gram may cost you 2,000 rupees, 3,000 rupees. Very costly. Very costly. Okay. Now there are many various forms of opioid. Okay. One very important form is heroin. Heroin. Okay. Or in fact, it is the most common abused opioid. Most common abused opioid is heroin. What is heroin? It is diacetyl morphine. Diacetyl, what is the chemical name? Diacetyl morphine. Okay. Diacetyl morphine. Okay. Again important. Now there are various street names like smack. Smack is nothing but opioid. Okay, so these are the street names. Another street name, brown sugar. So all these are forms of impure forms of opioid. Okay, so these are the street names. Okay. Now there are various ways, various routes to consume. So person can consume it orally, can consume through subcutaneous route, IV route. There is one very peculiar way of consuming this. This is known as, what is the name? It is chasing the dragon. Very, very, peculiar method of consuming. Someone who is consuming, he will very beautifully explain you what do they do. So what they do is they take a silver foil, they'll put the powder in a line, and then they'll burn, put a light below it. What will happen? It will generate fumes. And what they will do, they will snort the fumes, inhale the fumes. So they will chase the dragon. So this is chasing the dragon. Okay, so again, very peculiar method. Okay, so this is, so please write it again, very important, very interesting. Okay, now, everyone has written this? Yeah. Question was, which one came? Okay, we'll wait. Write it if you have missed anything. I'll take a break, we'll finish this, hardly around 10-15 minutes, we'll take a break. I want to finish this topic. Okay, then small topics will be left. Okay, now, next is intoxication. In what is intoxication? Someone has consumed large amount in small time. Okay, so like poisoning, intoxication. So again, this question came as a pharma question, but again, you can think it also is as a psychiatry question. So what are the symptoms which occur in intoxication of opioid? One is respiratory depression. Okay, so there may be depression. So, if you look into the eyes of this patient with intoxicated, what will you find? What will you find the pupil to be? It will be dilated. Very good. Pinpoint pupil. In intoxication, it will be pinpoint pupil. Or it will be meiosis. Very important. You look into the eyes, just like SRK would say, look into the eyes, because there are many very less substances which have these classical signs. These you can observe, okay, and ultimately patient can land up into coma and can lead to death. Alcohol withdrawal can lead to death. Opioid intoxication can lead to death. Okay, what is the treatment? Very good. IV naloxone. This was the question which was asked. IV naloxone. Okay, what is naloxone? Again, it's a new opioid antagonist, just like naltrexone. But it is a short acting. It's a short acting drug. Okay, please highlight this. Very, very important. This has been asked previously. Okay, so this has been asked previously. IV naloxone. So this is intoxication. Okay. So this is intoxication. Opioid intoxication comes to you with these symptoms. Intoxication, give IV naloxone. Okay. Next is withdrawal. Next is withdrawal. Again, I'll give you, withdrawal is very important. Highlight this because very peculiar withdrawal signs and symptoms are seen. Very peculiar. Okay. I'll give you a hint to remember. One is, you can remember there is pain. One important symptom is pain. There is muscle pain. There is bony pain. There is abdominal pain. Patient will come, doctor, I am having severe pain, crampy pain. So one is pain. Okay. So with symptom of pain. Second is, you can remember like this, there is leaking of the body outlets. So the body outlets, again, this is not the way they have written in the books, but it will become very easy for you to remember. Leaking of the body outlets. So what will be the symptoms? Diarrhea. Very good. Excessive sweating, sweat glands are also leaking. Very good. Lacrimation. What is lacrimation? Okay, very good. No, salivation, not any other thing. Running nose. What is running nose as? Rhino. Very good. Okay, so you can remember like this. So patient will be, doctor, I am having loose stools, very common complaint. Diarrhea is a very common complaint. If I don't take opioid, I start having these symptoms. Very, very common, symptoms. Then next is patient will do a lot like this in front of. What is this? Yawning. Excessive yawning. Excessive yawning. So you can see such peculiar symptoms are seen. Okay. Then there will be piloerection. So the body hair will become erect, like goose flesh. So what we say, wrong take your body hairs will become erect, goose flesh. Okay. Now, if I look into the eyes of this patient, what will I get? Yes. So in intoxication, it was constriction. In withdrawal, it will be dilatation. So there will be pupillary dilation. Okay. Or you can say mydriasis. Very important. Okay. So these are very less substances have these peculiar signs. So you should remember. Of course, there will be other symptoms like problems in there will be tachycardia, increase in BP, sleep disturbance. All those things will be there. But those are less specific. We discuss certain important specific withdrawal symptoms. So these are basically flu-like symptoms. Sometimes we say these are flu-like symptoms. Okay. So just like in a flu, you will get these symptoms. So these are flu-like symptoms. Okay. Again, please remember this is very, very important. They have asked question on this recently. Okay. So very important. Okay. Now, let's come to the treatment. Again, treatment will be in two phases. Detoxification will take care of the withdrawals. So we are detoxifying the patient, treating the withdrawal phase. Okay. Can anybody tell me any drugs which are used? Very good. Methadone. This question has been asked. So one is methadone. Okay. What is the mechanism of action of methadone? It's a mu agonist. It's a mu agonist. Right? And another drug starting with B, buprenorphine. So how you will remember? Morphine. Morphine is an opioid, buprenorphine. Okay. Buprenorphine. Again, the question has been asked on both. What is the mechanism? It's a partial mu agonist. So you can see just like in benzodiazepines for alcohol, patient was devoid of depressant, we gave benzodiazepine. Similarly here, body is devoid of opioid, we are giving from externally, we are giving opioids. Okay. One more drug which we can use, which is used for the management symptomatically. So patient may say, doctor, don't know, I don't want to take again opioids, give me something which will just agonist, which can be used. Clonidine. It's a alpha agonist. So basically it decreases symptoms. So it's symptomatic. Other symptoms like pain, you can give painkiller. Sleep problem, you can give something for sedation. So this is, we can manage just to decrease symptoms. Okay. So this is detoxification. Okay. So again the patient says, doctor, can I go home? You will say yes, but we want you to not take again. So there are two strategies which we can use. One is the opioid substitution therapy or OST, opioid substitution therapy or the OST. What do we do here is patient says, doctor, so please understand, when patient consume opioid, many times patient what they do is they inject, and when they use in the injectable form they share needles. You know, they share needles. And what can spread when they share needles? Infections like HIV. So this strategy in fact was started to reduce that. So what we say to the patient, okay, you are consuming impure form, you are consuming IV, come to us every day, I'll give you pure form. You take that pill every day and you enjoy the rest of it. Okay, so we are substituting impure opioid from to pure opioid. Okay, so again, what drugs we can use? Same drugs, methadone, buprenorphine. Okay. So I tell the patient, come to me. So please remember, we have to give this in supervision. Otherwise, if you tell the patient, okay, take this stock for 1 week, what he will do, he will sell that stock and take it for himself, will take impure form and he will earn money. So we give it under supervision. Second is, patient says, no doctor, I don't want opioid. Give me something that even if after it I consume opioid, I don't feel those effects. So what we can use? We can use naltrexone. What is naltrexone? Remember, it's a new opioid. Very good, antagonist. What does antagonist do? It blocks the receptor, isn't it? So suppose these are the new receptors. Okay, so these are the new receptors, and we have given naltrexone. So naltrexone is occupying these receptors already. Suppose patient consumes opioid from outside. Will the opioid have its effect? No. So patient will feel that I am not getting that same effect with opioid. So he may decrease. Okay. So again, this table is very important. Strategies to treat opioid dependence. Okay. Again, very simple. Many times questions have been asked. Okay. Now, if you give me 10 minutes, I'll finish this topic, then we'll take a break. Or you want, shall I finish this topic? Then we take it. Okay, good. Because now we have discussed the two most important ones. Now we just need to remember certain facts about others. Cannabis. It is the, what was it? It is the most common illicit substance. Cannabis is derived from which plant? Very good. Cannabis sativa. Very good. Also known as hemp plant. Anybody seen cannabis plant? Of course, you must have seen. Okay, you might have not recognized, but you must have seen. Very common. How many done from Russia? See there, seen there? You seen not there? Okay. Okay. Now, so what are the various forms? Can anybody tell me what are the various forms of cannabis? Let's write down. Afim is heroin. Afim is opioid. Charas, very good. What we use in Shivratri? Ganja. Marijuana. Okay. Then hash or hashish, very good. Weed. Yes. So weed, these are the names. Okay. So very easily be accessible, you know, very cheap. Very cheap. Okay. And anyone has tried? Okay. So these are the various forms. Okay. So basically depending on basically what is the psychoactive ingredient question? Very good. Psychoactive ingredient, that means yes. Yeah. So basically what do I mean by this is, what is that psychoactive ingredient Let me write it again. What is that ingredient because of which patient gets those effects of cannabis? So there is one chemical known as delta 9 tetra hydrocannabinol. Okay, delta 9 tetra hydrocannabinol, also known as delta 9 THC, MCQ, has been asked. Okay, so all these forms basically vary based on the concentration of this compound in there. Okay, delta 9 tetrahydrocannabinol. Okay. So again, very important. This is very important. Question has been asked. Now, few important terms related with cannabis you should remember. One is, so everyone has written this. So write it. It can induce psychotic disorder. So if someone consumes cannabis can induce psychotic disorder, which is like an acute psychosis. It is like an acute psychosis. Okay. But please remember, some of those patients who are lucky, they ultimately can develop schizophrenia. So in fact, cannabis is a risk factor. Cannabis is a risk factor. So cannabis use is a risk factor, full-blown schizophrenia, which may be a very long illness. Some of us, what we have identified is there is a gene. We will not discuss that gene, but there is a gene. If we have a allele of that gene in any of us, and even if we just consume cannabis once, we may ultimately develop schizophrenia. So what I would advise is never touch this substance. Okay. They are allowed, yes. It is yes. And now what they are seeing is their generation, their young generation who have consumed cannabis for a long time, they are seeing cognitive impairment. Okay. So this is one substance you should not think of, because we have seen patients going well, having a good life, develop schizophrenia. Okay. Now second is amotivation syndrome. So from the name itself, you can see amotivation syndrome. So it occurs because of long heavy use. So someone using it for a long time, heavy use of cannabis may develop amotivation. So they develop unwillingness to do things. So family members will say, doctor, he just sits idly, does nothing, shows no motivation to do anything. So this is amotivation syndrome, again important. Okay, amotivation syndrome. Last point about cannabis which I want you to remember is flashback phenomena. Flashback phenomena. What is flashback phenomena? Recurrence of, let's write down, then we'll discuss. Recurrence of cannabis experience in absence of current use. Okay. So flashback phenomena means, so suppose someone has consumed cannabis 1 year back and he got some symptom. He said that I was elated, I was excessively happy, my sleep decreased during that time, and that lasted for, let us say, 6 hours. So 1 year later, currently the patient is not using that substance, but that symptoms have again come back as a flash. So this is flashback phenomena. Suddenly the patient says, doctor, I'm sitting and suddenly those symptoms, experience are again come back. This is flashback phenomena. Okay. So this is flashback phenomena. Right. So these are the important terms related with cannabis which you should know. Again, treatment wise, there is no specific treatment. Symptomatic management. Sometimes there is no treatment, you just take care of the vitals, patient after some time will improve. Okay, so basically we do symptomatic management. Suppose there are psychotic symptoms, we will use antipsychotic. There is anxiety, you will use SSRIs. Sleep disturbance, you may give benzodiazepine. So depending on the symptoms, right? So that is I'm saying these are very small substances, small important things we need to remember. Again, no specific drug. Next is a list of hallucinogens. Next is a list of hallucinogens. I'll just show you how much is left. Just let me know this much is left. Okay, I'll just finish this, then we'll start new topic and we'll try to finish quickly. Okay, just names you have to remember here. There are then set of substances known as hallucinogens. Okay, from the name itself you can see they are hallucinogens. They can produce hallucinations, psychotic symptoms like delusion. Those can be precipitated. Okay, one substance is first is PCP. Question has been asked in 2018 on PCP. I'll tell you what was the question. It is all. This is basically phencyclidine. PCP is phencyclidine. The question which was asked was, what is the other name? Can anybody tell me what is the name of PCP? It is angel dust. Such fancy names they keep. Dust of angel. Such effect they get, after consuming such high they go there, such fancy name they write. And this was the question which was asked. This was the question which they asked, what is angel dust? Simple question. Okay. Next is ketamine. Ketamine is what? It's an anesthetic agent. Okay, so ketamine again it is also abused. Okay. Next is LSD. LSD is lysergic acid diethylamide. LSD, lysergic acid diethylamide. Lysergic acid diethylamide, LSD. Okay. It also can cause flashback phenomena. Flashback phenomena may also be associated with LSD. Okay. Right. Then is, just remember psilocybin. Psilocybin, from which it is procured. It is derived from mushroom. Sometimes a lot of the mushroom poisoning they say, So again, mushrooms, psilocybin. Okay. Another question which was asked from this topic on MDMA. MDMA. What is MDMA? Methylene dioxymethamphetamine. Methylene dioxymethamphetamine, MDMA. It is also known as, again, a very fancy name, ecstasy. What is ecstasy? Ecstasy means to be in a state of bliss. Me and God are one. Aham Brahmasmi. Patient goes to that state, when meditators may tell, so they reach that state, they say it's a stage of ecstasy. Okay. So MDMA, again, this was a question which was asked. Ecstasy. Very good. Ecstasy. Then is Datura. Datura is what? Very good. It is anticholinergic. So all the anticholinergic signs, symptoms you may get with Datura. Okay. We'll discuss in detail in forensic also. Okay. Stimulants. Next, again, this is a separate heading. Although stimulants, two stimulants I'll tell you, but I am keeping it here because these stimulants can also lead to psychotic symptoms. Okay, we don't say them to be hallucinogens, but I am discussing here only because otherwise you don't get confused. Because these can also have those symptoms like delusions, hallucination. Two important substances which you should remember here is, one is very famous cocaine. Okay. Now, can anybody tell me something related with cocaine? Now, it's a stimulant. Please understand. This was a 2021 question. It's a stimulant. What will be the symptoms of cocaine? Dizziness, hyperactivity, isn't it? It's a stimulant. Tachycardia, pulse rate will be high, then there will be sweating, there will be headache. So all those symptoms will be there. Patient may also develop scratch marks. Why? Because yes, this was the question which was asked in 2021. Tactile hallucination. So you may get scratch marks. Remember cocaine bugs? So, such simple questions, again, they will just manipulate the question. You have to be careful. Okay, second important point about this I want you to remember is speed balls. Again, this has been question asked multiple times. What are speed balls? Speed ball means someone is combining two substances which is getting a very speedy effect. Of course, one substance is cocaine. What is the other? Yes, heroin or opioid. Please remember this. This has been asked. Will be asked. Such questions will be asked. Cocaine. Again, please remember treatment wise. I am not telling you the treatment because again all this treatment is symptomatic. Okay, symptoms treat the symptoms. Okay. So one is cocaine and second is amphetamine. Okay, amphetamine. Again, amphetamine is also a stimulant. Where it was used in the treatment, which disorder? Very good. ADHD. Very good. Okay. Please remember this. This was a 2021 question. So, such small questions are asked from this topic. Alcohol, please do remember. Last substance is tobacco. Which is the psychoactive substance in tobacco? Very good. Very good. Is nicotine. Very good. Again, there are various forms of tobacco. There is smoking, and there are also chewable forms of tobacco. Like, cigar, cigarette, bidi, hookah, tobacco. So there are many forms, gurkha. So, in one cigarette, how many substances compound are there in one cigarette? One simple cigarette. How many chemicals are there? Can anybody make a guess? 9, 200, 7,000 in one cigarette. And only this one substance is responsible for addiction. And many of those other compounds are carcinogen. Okay. So man is a very strange phenomenon. Okay. Treatment. One is nicotine replacement therapy, NRT. Just the last table, we'll take a break. So one is NRT. So what we will tell the patient, okay, you are consuming something which is impure form, which is carcinogenic, come to us, I'll give you pure form. Okay, and you will be, at least you will not get those problems. COPD can also occur, chronic use, so many things can occur. So it is available in the form of chewing gums. Anybody has tried chewing gum? Yes. Lozenges. Lozenges are basically, they are toffees like thing, you have to just suck them. Yes. Then yes, there are patches. Yes. Sublingually you can give. There are inhalators. there was something known as e-cigarettes. So patient would say that, doctor, जो ये करने में मजा आता है ना, वो chew करने में मजा नहीं आता. No, I like that doing that. So e-cigarettes were developed. E-cigarette means electronic cigarettes. But now we are seeing that these are banned. Even in the world, WHO has recently given an advisory. They have also found it has carcinogens. India had banned quite early. Even WHO has given advisory, it should be banned. Okay, so e-cigarettes are no longer used. One strategy is this, right? Second is we can use certain anti-craving agents. Two important drugs, and we'll take a break. Again, please remember the names of these drugs, very, very important. One is Verniclen. Verniclen. Important is to remember the name and the mechanism of action. It's a partial agonist, just like buprenorphine, it is also partial agonist. Now you've studied anticholinergic and you discussed cholinergic system. What are the two N and M you have read? N nicotinic receptors, muscarinic receptor. This N-nicotinic is this nicotine. Okay, so nicotine is basically stimulating the receptor, they are known as nicotinic receptor. So this is a partial agonist of alpha 4. 4 is coming first, beta 2, N type of acetylcholine receptor. Okay. So you can see, what we're doing. So basically it is stimulating nicotinic receptor. So we give you partial alpha 4. In the option they will give you alpha 2, beta 4. So remember 4 is coming first, alpha 4, beta 2. Right? Last is bupropion. We have discussed this drug so often now. It's a NDRI. The question which was asked was direct question in 2018, antidepressant use in smoking cessation. That's it. It's an antidepressant 1. So one uses, let's try to just write the uses. So it's an antidepressant, one use. Second, where it was also used? Very good. ADHD. Stimulant, non-stimulant? Non-stimulant, remember? And third is smoking cessation or tobacco cessation. Okay, even chewable tobacco also. So in tobacco, right? So this is again very, very important. Let's take a break. Let's start at 7:15. We'll start at 7:15 for the last session. Now I think audible. Now is it audible? Yeah, now it is audible. Audible, right? Yeah, I'll discuss the question. Don't worry in the end again. Just give me 5 minutes. I'll discuss all the questions in the end. Okay. I hope now I'm audible. Yeah, great. So let us discuss some very short topics, small topics. Again, these topics nowadays they are asking less, but in the past, a lot of questions were asked from these topics, so you should be aware of them. Okay. Is it raining outside? Sleep disorders. So let's wake up from sleep. For the last session, let's all, I know it becomes tiring at times, but let me tell you, everything will be heard. Okay? I know all of you are putting a lot of efforts. Everything in the end will be worth. When you get the scorecard and when you tell your parents, that will be worth. Okay. Sleep is made up of 2 states. Okay. So this is one concept. Again, if you have done physiology, good. I'll just briefly tell you this concept. Okay. So there are 2 sleep states. 2 sleep states. Okay. One is NREM or the non-rapid eye movement, NREM sleep, right? So you can understand one is NREM sleep, non-rapid eye movement, and one is the REM sleep, rapid eye movement. Okay, NREM sleep and right. So NREM sleep and REM sleep. So write it down. Okay. So basically, we have started with sleep disorder. So there are two types of sleep: NREM sleep and REM sleep. If I ask you, so suppose patient is you, so not patient. Let us say someone is awake. So I am telling you that there are two stages of sleep. So someone is awake. So suppose today when you go and you want to sleep, you lie down on the bed and you sleep. Which is the first stage you will encounter? You will encounter, very good. You will encounter NREM. Okay. So we are talking about sleep disorder. This is the first slide only. Okay. So you will enter NREM. After some time you will reach REM. Then what will happen? After some time you will again go to NREM. Then REM. This is how it will fluctuate and ultimately you will wake up in the morning. Okay. Everyone understood? Which is the first stage? Okay. Now. Okay. Yeah. Okay. Right? NREM and REM. Okay. So we encounter NREM first, then REM, and this is how it fluctuates, right? So let's move. Okay, I'll show, don't worry. If you missed anything, I'll show in the end. Okay, NREM and REM, right? Let's move. So please remember. So now again, this one small thing which I want you to remember. NREM is divided into various stages. NREM is divided into various stages. Earlier classification was stage 1, stage 2, stage 3, stage 4. Earlier classification of NREM was stage 1, 2, 3, 4. Newer classification, what they have said, stage 1 as N1, stage 2 as N2, stage 3 and 4 they have combined as N3. Okay, so now the stages of NREM is N1, N2, N3. So persons fall asleep, first comes N1, N2, N3, REM. Okay, so this is how it goes. Okay, so NREM and REM, two stages of sleep. Okay, NREM and REM. Okay, is everything done? Sleep has been discussed. So everything, waves and all those things have been discussed. Great. Great. Then things will become easy for us. Even if someone has not discussed, don't worry, we'll discuss the basics. I'll discuss the basics and I'll tell you how to correlate. Okay. So everyone is done? Right. Now, make this table. Before coming to the disorders, make this table. Yeah? Yeah. This was the last one. Okay. Right? Okay. In the end, any slide from any of the day's session you have missed, and there will discuss. Okay, if you want to repeat any slide, we'll show you. Now, we have NREM is known as orthodox sleep. NREM is known as orthodox sleep. REM is known as paradoxical sleep. Orthodox means the normal sleep we know of. Okay, but REM is known as paradox. What is the paradox? That means something is happening in REM which should not have happened. Can anybody tell me right now if I do a EEG of any of us? Which wave will we find? Very good. Beta wave. Beta wave is basically found in EEG when you are awake and eyes are very good, open. When are alpha waves found? Very good. You are awake but eyes are closed. Right? Every one of us know this concept. If I do a EEG of a person who is in REM phase, what wave will I find? We find beta waves. Sometimes alpha also, but beta waves. Beta waves which are telling us that the electrical activity is high. So in sleep, generally after NREM, REM should be an even deeper sleep. But here, what is the paradox? We are finding that the brain activity, electrical activity is very high. Although the person is sleeping, but the electrical activity is very high. This is the paradox. That is why we call it as paradoxical sleep. So now tell me, brain activity physiological functions will be low, normal or high in NREM? Low. BP, pulse rate, brain activity, everything will be low. Okay. While what is happening in REM? Normal. It will be normal or it can also be high. But one thing, except this concept, if you remember, you will be able to tell me which disorder is of which phase. Understand this. The brain electrical activity is high. Person is sleeping. Don't you think if the brain is active, you may do certain things, but you are still unconscious, which may harm you? Isn't it? Brain is active, body is sleeping. But since the brain is active, it can lead to, you can just get up and start moving. It can harm you. What nature, God, whatever you call that force has done is, because the electrical activity is very high, all the activities are high except muscles. Muscle tone is low, is in a state of paralysis. So that the body does not, so the person does not get harmed. So many times when someone is sleeping next to you, you are riding and suddenly his neck falls. After some time, so he may have entered REM. The body is now in a state of paralysis to prevent any injury to the person. So tell me, if any sleep disorder has movement, will it be NREM? Will it be REM? NREM. It will be NREM because in REM muscle tone is in a state of paralysis. Any movement, okay, will be in NREM. So we'll discuss. So now this will be very easy for us to remember. So body movements will be no. So there will be nil body movement. Sorry. Body movements can be present here, may be present here, they will not be present, isn't it? Okay, may be present, not always, but maybe when sometimes if someone is lying down, may change his position. All these things are occurring in NREM. Okay, now penile erection. Sometimes after waking up in the morning, the penis may be in a erection form. There may be erection of the penis. In which state it is seen? Penile erection is absent here, maybe is present in this stage. Okay, it is because of blood flow. Okay, it's because of blood flow. Right? Now, this again tell me, dreams we take in both the stages. In both phases we have dreams. Which dreams we remember? REM or NREM? So let me tell you, right the way I am writing. Dreams in NREM, right the way I am writing, are not remembered. Right the way I am writing so that you will never forget. You will always remember. They are not remembered. Dreams of NREM, not remembered. While dreams of REM are remembered. Okay, so again, these tricks sometimes help, otherwise you always get confused. Okay, so again, if there is a sleep disorder in which person remembers the dream, it will be a REM disorder, and if he does not remember the dream, it will be an REM disorder, right? So again, this concept will be very handy. Let's start.
Sir, is deja vu related to this topic?
It's a basically it's a phenomena which occurs, not related to sleep.
That's the sleep jerk.
That can happen. Sleep jerks can happen. Will this sleep jerk will be in which stage?
REM.
It will be in
No,
NRE. So let us discuss some important disorders, parasomnias or disorders of partial arousal. Parasomnias or partial arousal means patient appears to be aroused partially, although he is sleeping. Parasomnias or disorders of partial arousal, right? Okay. So first we will discuss NREM group of disorder, NREM sleep arousal disorders. Okay. So we are discussing parasomnias or disorders of partial arousal. First we are discussing the NREM disorders. That means person is sleeping but some features of awake state is there. Okay. So first is somna. And somna means sleep. Ambulism means someone is ambulatory. Ambulatory means moving. Right? So somnambulism is also known as very good. Sleepwalking. Very good. So person is sleeping, but he is still showing some movement. So person engage in variety of complex behavior. Please remember this while the person is unconscious. This question was once asked. Which of the following is not true about somnambulism? One option was person is conscious. No, he is unconscious. So person will get up, move outside, may do some activities to try to wake him up. He will not remember what he has done. Okay, so this is somnambulism. Right? Again, generally it spontaneously goes away. It occurs in children and adolescents and generally spontaneously it goes away. Sometimes if you require treatment, we may use sedatives like benzodiazepines. But many times it spontaneously goes away. You don't have to do anything if the person is sleepwalking. Just direct him towards the bed. While sleeping, only the person will go to bed and sleep again. Don't try to wake him up. He will be frightened, he may attack you. Okay, don't do that mistake. Okay, so this is somnambulism. So everyone understood? Next is somniloquy. Somniloquy is also known as sleep talking. Very good. Sleep talking. So patient, you might have even normally in your day-to-day, you might have seen any of your family member doing this in the sleep. They're talking. You ask him, when they wake up, what were you talking about? They don't remember. Okay, because again the person is unconscious. Okay, again if it is mild, you don't have to do anything. If it is severe, you may use some sedatives like benzodiazepine, right? Okay, this is somniloquy. Then next is sleep terrors. Next is sleep terrors. Okay. What happens in sleep terrors? Sudden arousal. Patient is sleeping in the night, middle of the night, patient wakes up, appears fearful, intense fearful, as if the person has seen a bad dream. Like in the movies, the hero just shouts in the middle of the night, wakes up. In old movies, nowadays they don't show this, but in many old movies you will see these scenes. Can the person remember the dream?
Yes.
It's in NREM. Now again tell me, will the person remember? NREM, not remember. NREM, right? So the person will not remember the dream. Right? So person will say, I don't, doesn't it happen to all of us? In fact, many times when we wake up, we remember the dream very vividly. This happens sometimes, we say, oh my God, what was that dream? I can't remember. So that would be that you were in that stage of the sleep, right? So this is sleep terrors. Okay. Then last is bruxism. What is bruxism? Very good. teeth grinding. So like this, grinding the teeth. In the middle, in the sleeping state, patient is grinding the teeth grinding. What can happen because of teeth grinding?
Tongue bite.
Tongue bite can occur. The teeth can also, with time, there will be erosion of the enamel. Right? So the teeth, again, you may have to go then to dentist. So what you can simply do is you can put a teeth guard. Before sleeping, these are plastic, guard, and just put them so that the teeth are not injured. You can use teeth guards. Okay, simply that can help. Okay. So now you can see again there is movement here. If someone asks you bruxism is seen in which stage, you will say there is movement. It is NREM, right? A sleep terror, dreams are not remembered. It is NREM. So again, those concepts will be very helpful if you come to the disorder, right? Next important group of disorder are the REM disorders. Okay, REM, sleep arousal disorders. Second are the REM disorders. Okay. So next is nightmare disorder. In REM, so this is a REM disorder, nightmare disorder. Name is telling you again, sudden arousal, sudden wake up with intense fearfulness. Suddenly, patient wakes up all sweating, fearful, anxious. And when you ask the person, does the person remember the bad dream? Yes, it's nightmare. It's a bad dream. So person remembers. It's a REM disorder. Person remember the dream or the nightmare. Okay, so now you know the difference between sleep terror and nightmare disorder, right? The difference is in one you remember, in the other you don't, right? Okay. Last and most important topic of this sleep disorder, which we will discuss, is narcolepsy. Everyone has written this? Right. So you can just write down. So next is narco. Very, very important. Put 2-3 hashtags over this. Very, very important. Narcolepsy. So narcolepsy is a disorder of sleep. Which sleep stage? REM. Well, there are 4 symptoms in narcolepsy. First is sleep attacks. Sleep attacks is excessive daytime sleepiness. So patient has excessive urge to sleep. Excessive. Patient is going to the office, suddenly sleep attack is so sleep is attacking. Patient head gets stronger, he sleeps on the road. He's giving a presentation, middle of the presentation, he gets that urge, he sleeps on the stage. Such strong urge, which the person is not able to prevent. So this is sleep attack. It is the most common symptom of narcolepsy. Okay. So one is sleep attacks. So this is basically hypersomnia, isn't it? Hypersomnia. What was catalepsy? Posturing, abnormal maintenance of posture. Narcolepsy, you can remember it like this. Narcolepsy don't has catalepsy. It has opposite. Narcolepsy has cataplexy. Remember it like this so that you will not get confused. It is opposite. Again, it is also something related with muscle tone. So there is sudden loss of muscle tone. Patient may even fall. Yes, we discussed catalepsy and catatonia. Yes, this is cataplexy. And this may be increased by emotions. So you can see, can anybody see here, can any component of REM is there in this symptom? Isn't it? Muscle tone is lost. So that is person is awake, talking, suddenly REM has entered and patient suddenly lost the tone. So patient, and these are exaggerated by emotions. Patient is sitting, you crack a joke, he starts, suddenly falls. Okay, so these are exaggerated by emotions. Okay, so this is, so patient is standing, suddenly entire body falls. He's conscious, he's not sleeping. Okay, so this is cataplexy. Third symptom is sleep paralysis. This occurs when the person wakes up in the morning or whenever the person wakes up. So person wakes up but is unable to move the body. It is paralysis. So patient wakes up from sleep, he opens his eyes, he's conscious, he knows what is happening around, but he is not able to move. What has happened? The REM has extended into the wakeful state. This happens for few seconds to few minutes, but it's a very terrible symptom to have. Isn't it? Patient will feel that what is happening. Right? So this is sleep paralysis. And the last, which we have already discussed, remember this? Hypnagogic and hypnopompic hallucination. Remember? Gogic occurred when someone is going to sleep. Very good. So patient get these hallucinations. Pompic when person is coming out of sleep. These are hallucinations. So I told you we will discuss here also. So these are the 4 symptoms of narcolepsy. It is sometimes all the symptoms will be present, sometimes 2-3 symptoms may be there. Okay. Please highlight this, very important. So they may say a person is sitting with his friends cracked a joke, patient suddenly fall down, suddenly fell. What is this symptom? Cataplexy. They may ask you what is the diagnosis? Narcolepsy. What is the treatment also there? So this is how clinical cause. Can anybody tell me what is the cause? Deficiency of deficiency of a neurotransmitter. Deficiency of hypocretin. Very good. Hypocretin. Hypocretin is a neurotransmitter which is required for wakefulness. Hypocretin, also known as orexin. Can anybody tell me hypocretin is seen in which part of the brain? Very good. Hypothalamus. Hypocretin, hypothalamus. Okay. Again, this has been asked. Okay. Now, coming to the management, first is we use certain regimens, certain therapy techniques like forced naps. We tell the patient use this technique of forced naps. So we tell the patient you forcibly take frequent daytime naps so that at the important hours of the day you don't fall asleep. For example, you're driving. If you fall asleep, there will be accident, isn't it? Tell the patient take naps in between. Okay, so that the hypersomnia may not come. Second is one important drug. Very good. Modafinil. Where we had discussed modafinil? Very good. It's an alpha-1 agonist. It's a stimulant. There I told you it is not FDA approved, what we use there, but it is here for this condition. It is FDA approved. Okay, it is FDA approved, right? Alpha-1 agonist. It's a stimulant. So because we want to keep the patient awake, so to prevent hypersomnia, we can give modafinil, right? Modafinil. So this is very important topic, narcolepsy. Please remember this topic. Now, of course, there are other type of disorder. Again, we'll not discuss in detail. There can be dysomnia. This was parasomnia. Dysomnia basically can be wherein the sleep duration or quality is getting affected. Dysomnia. It can be insomnia, and it can be hypersomnia. So this is also here we divide sleep disorder as like this. Okay. So there may be many causes. Insomnia we have discussed, even in depression, insomnia can occur, hypersomnia can occur, many conditions. And sometimes it may be without any cause. Treatment here again, insomnia we may use sedatives like benzodiazepine or your Z drugs. Any Z drug? Zolpidem. Yes, so all those Z drugs we can use. Okay. And hypersomnia again we can use drugs like modafinil. Okay. So just remember, yes, there is something known as dysomnias also. Okay. So this is about sleep disorders. Okay. Everyone has written this? Okay. So narcolepsy again, let me tell you, very, very important. Because clinical questions are asked, they may ask. Somnambulism has been asked recently in some other exam. So such clinical questions are very common. Previously, they would just ask direct questions. Okay, and of course, physiological questions related with sleep can also come. Okay. Now, next is sexual disorders. Next is sexual disorders. Again, certain important disorders we will discuss here. Okay. First is the erectile disorder, male erectile disorder or erectile dysfunction. Okay. So basically, you can write before this also you can write that the sexual response cycle, okay, or the sexual response cycle. So basically, whenever people engage in sexual activity, they go through certain phases. I'll just tell you briefly those phases. One is the phase of desire. Okay. First phase, this is in this sequence it occurs. First is the desire to engage in sexual act. Second is the state of excitement. Second is the state of excitement. Now in excitement state, of course, what will happen to the physiological processes of the body? What will happen? They will increase pulse rate, sweating, BP, all those things will increase. Yes, all those things will important thing, and you should remember in males there will be penile erection. I'll tell you why I'm telling you this here, because when we discuss disorder it will become very important. In females there will be vaginal lubrication. Okay. So if there is some problem with erection, it will be a disorder of which stage? Excitement. This question has been asked previously. Isn't it? If there is problem in erection is occurring in E for erection, you can remember. E for excitement, E for erection. Okay. Third stage is the stage of orgasm. Orgasm means peak pleasure, state of pleasure, excessive pleasure. Okay. Again, in males, what will happen? There will be ejaculation, release of semen. And in females, there will be vaginal contraction. Right? So if I ask you if there is any problem with ejaculation, if there is any problem, it will be a disorder of which stage? Orgasm. Very. It is the smallest stage. This is the smallest. It may last for a few seconds only. Okay. Orgasm. And the last is, so now what will happen? Everything will come back to normal. All the body changes will come back to normal. So it is resolution. So they may ask you this question which we discussed. Also, they may just ask you to arrange in the sequence. Okay, so you should know the sequence. Okay. So everyone understood this concept. Problem in erection will be problem of excitement phase. problem in ejaculation will be a problem of orgasmic phase. Okay, these questions have been asked. So again, you don't have to mug up. When we are going to discuss disorder, you just remember the concept. So let us come to the individual disorders. Male erectile disorder or erectile dysfunction, what is happening? Marked difficulty in either obtaining or maintaining erection. Okay. So marked difficulty in either obtaining, the person says, doctor, I don't get an erection, or I get an erection but I am not able to have a proper sexual intercourse. Okay, so I am not able to maintain. Okay, either obtaining or maintaining erection, right? Causes, again, it can be psychogenic causes, can be organic. Person with depression, person with anxiety may not be able to have, because for having these things the mind should be calm. So it can be psychogenic, okay, where the problem is in the mind. It can be organic. Organic means there is a bodily cause. For example, problem in the vessels, there is arteriosclerosis, damage of the nerves, okay, damage of the nerves. Give me a second. Yeah. So, which is the more common cause? Psychogenic is the more common cause. Okay, most common cause. Now, there is one question I will ask the patient which can differentiate whether it is psychogenic or organic. Yes, I will ask early morning. In which stage it is occurring? Early in REM, right? So I will ask, so many times when you wake up in the morning, do you feel the erection? In which stage will the patient say, doctor, I feel? Psychogenic. Because organic, there is some organic cause, he will not be able. Okay, so early morning erection will be present here, absent here, right? So clinically also we can sometimes differentiate. Of course, we can do investigations also. Coming to the, everyone has written this, right? So coming to the treatment, any group of drug which are useful? Very good. Phosphodiesterase 5 inhibitors, PDE5 inhibitors. Phosphodiesterase. So basically what they do is they increase the blood supply. Erection is occurring because of increase in the blood flow. They increase the blood supply. Any drug Sildenafil. Any brand name of sildenafil? Viagra. When it was first time launched in US, it was sold as chocolates and toffees. Sildenafil. Tadalafil. All the fills. Any other? Vardenafil. So all the fill. Sildenafil, tadalafil, vardenafil. Of course, you should be careful when the person is having some cardiovascular problem. Now again, this problem may occur in elderly people who may also have associated cardiac problems. So you should be careful. Okay. Okay. So phosphodiesterase 5 inhibitors. Now again, there is one important therapy which has been used which is asked many times, psychotherapy. In fact, for any sexual disorder, okay, we use what is known as dual therapy. In fact, this may be used for both, for any sexual disorder. So you may ask, sexual therapies, dual therapy is used for any sexual disorder. In fact, this was one time question asked, dual therapy used for eating disorder, sexual disorder, sleep disorder, none. Answer was sexual disorder. Dual means we don't treat the patient, we treat the couple. Okay, we treat the couple. Dual therapy, also sometimes known as dual sexual therapy. Okay, so it has basically various techniques, various stages. One is non-genital. Right, let's just write down. So various techniques like sensate, focus techniques. Okay. It can be genital sensate, it is non-genital and genital. So basically these are various steps which we use. So this sensate focus technique is specifically used for erectile dysfunction. Okay, erectile dysfunction or erectile disorder. Right? Okay, again this has been asked in the previously. Direct one-liner questions have been asked from this topic. A lot of one-liners. Okay, you see the last 5-6 years paper. In the past, a lot of one-liners have been asked. So this was about erectile disorder is a disorder of. So you can write it is a disorder of which stage? Very good. Excitement phase. Please remember this. It is a problem of excitement phase. Next is premature ejaculation. Okay. So what is happening from the name premature ejaculation? There is ejaculation is occurring before or immediately after insertion. Okay, immediately after the insertion in the vagina. So prematurely. Okay. So prematurely it is occurring. It is a disorder of which stage? Orgasm. Very good. DSM-5 also says DSM-5 also gives a duration. It says if it occurs, ejaculation occurs within less than 1 minute, then we call it as premature ejaculation. Okay. So one is you should know what is premature ejaculation. Second is there are many treatment questions. Twice question have been asked on the treatment, especially the therapy. So please remember the name of these therapies. Okay, so we use certain therapies for premature ejaculation. One is squeeze technique. Okay. Second is stop start technique. Anybody seen any series related with Masters and Johnsons? Anybody here? Yeah. So those are the people who in fact developed these techniques. Okay. Stop start technique. Again, don't go and watch that. Give your exam, then what? Then you can ask, I'll tell you. If you are interested to watch psychological drama, I'll tell you. Okay. So premature ejaculation, both the questions have been asked previously, remember. Squeeze technique, stop start technique used for premature. So basically we're trying to increase the time of ejaculation. Okay. Now in drugs, one important sometimes side effect of one drug is used in the treatment of the other. SSRIs have a side effect. SSRI also has sexual side effects. Please remember this. They have one very peculiar side effect. So there is one side effect of SSRI. They delay ejaculation. Okay. So side effect of SSRI is used. So what it is doing, it is delaying ejaculation. This is what we want. Okay. So we can use SSRIs like sertraline, paroxetine. Okay. So the side effect of one is used, and also at times these patients also have anxiety, depressive symptoms. So it will take care of those things also. So the psychogenic component will also get treated. Okay. So again, important questions have been asked on the names of these therapies. Please remember these. Highlight these names. Okay. Everyone has written. Okay? Okay, sure. Now just few other disorders which we discuss. Again the names. Again direct question one. Again what I am trying to tell you is a lot of one-liners have been asked in the past. Recently for the last T4 exam, not much question has been asked on the topic, but now you can expect because these topics have been untouched for a while. Okay. Now other disorders. Dyspareunia. What is this? Means discomfort. Yes, it is pain during intercourse. Okay, it could be in the beginning, between or after. So pain during intercourse. Okay. It can occur to both females or males. Okay. Pain during intercourse, dyspareunia. Dys means discomfort, pain. Okay. Dyspareunia. Next is vaginismus. It is the name is only telling there is contraction or constriction of vagina. So there is involuntary, not deliberate, involuntary muscle constriction of lower third of vagina. So what will happen? Which makes penile insertion difficult. Okay. So the vagina is constricting. So the penile erection is not happening. Difficult. Okay. Again, questions have been asked from this. Okay. Nowadays in DSM-5, what we have seen in fact clinically, that many times patient who has dyspareunia, so we talk about female patients, they also have vaginismus. So these two conditions generally coexist. So DSM-5 says let's make a single disorder. So DSM-5 has combined these two conditions and named this disorder as genitopelvic. Pain means dyspareunia, penetration, difficulty in penetration means vaginismus disorder. So genitopelvic pain penetration disorder. So they have combined dyspareunia and vaginismus. Both these two they have combined and made a single entity. Okay, please write this. Okay, so again this may be asked. You may get a clinical question. So now the diagnosis is genitopelvic pain penetration disorder. Okay, right? Right. So you can see these are very small topics, but again questions have been asked from these. Last 2 points about sexual disorder. What is nymphomania? Excessive sexual desire in males or females? In females. In females. Again, this has been question asked 2017. Question has been asked on this nymphomania. And what is satyriasis? It will be excessive sexual desire in males. Very good. Okay. Nymphomania, and again questions have been asked from these, very, very important. So have a look again. Simple direct questions have been asked. Okay. Let's see. Answer. Okay. Nymphomania in females, satyriasis in males, right? Okay. So what are you going to do now? You will all be having dinner. So before that, okay. What you missed? Let me know. Satyriasis. See the neighbor's notes. Satyriasis. Okay. Right. So of course we need. So let us talk about some eating disorders. Again, 2 eating disorders. Very basic points we are going to discuss. Question on this has been recently asked, 2019. I told you. In fact, it was in the option. The answer was not eating disorder, but it was there in the option, and that created confusion. Eating disorders. First is anorexia nervosa. What is the meaning of anorexia? Loss of appetite, isn't it? We say in diseases like liver disease, there is loss of appetite, anorexia. But please understand, in anorexia nervosa, there is no loss of appetite. There is no, it's a misnomer. It's a wrong name. There is no loss. The patient never says, doctor, I don't feel my appetite has decreased. No, that never happens. There is never loss, but the name is anorexia nervosa. More common in males or females? Females. Much more common. Much more common. Okay. In fact, young, adolescent, young adult females. Okay. Patients with adolescent 14, 15, 16 can come to us with this problem. Very difficult problem. Anorexia nervosa, very difficult problem. Okay. I'll tell why. Okay. Now, so everyone has written this? Right. So let us come to the characteristics, clinical features. One is there is disturbance of body image. There is a disturbance of body image. Patient perceive herself as fat. So patient has a disturbed body image. Patient perceive herself to be fat. Let us say this is the normal body structure. Let us say this is a structure of an obese person. Let us say the patient is this, even less than normal, underweight, but patient perceive herself to be this. So patient feels that I am fat, I am gaining weight. So there is a disturbance of body image. Okay, first symptom. Okay. Second is there is excessive fear of fatness. Excessive fear of fatness. Oh my God, what if I gain weight? Excessive fear. There is a fear to gain weight. Okay. And what does the patient now do? Restriction of energy intake, resulting in significantly less weight than even normal. What is BMI? Significantly decreased, even 14, 15 BMI, severely underweight, and still patient is not eating only. Yes. So that is when the patient does not accept. We ask the patient, please eat something, or the patient says, no, I gain more weight. Sometimes we have to do, put the rice to nasogastric. We put once, patient will remove it. I don't want to eat. Okay, such severe. That is why it's very difficult. So these are the problems which occur. Okay. So these symptoms should be present then only. So you can see never in the symptom I have mentioned loss of appetite. Patient is not saying that my appetite has decreased. Patient does not want to eat because there is a fear and fat I gain weight. Okay. So these are the three important symptoms. In DSM-5, there was one more symptom. There was a fourth symptom which now has been removed. Okay. Which was amenorrhea. Okay, amenorrhea. Cessation of menses. Earlier it was there as one of the criteria, but DSM-5 has now removed this criteria. It says yes, females may have this, but it is no longer required to make the diagnosis. Okay, so it is no longer required. Okay. So basically, what is happening? What is happening here? Can anybody tell me? It's a state of starvation, isn't it? Patient is starving. So all the signs and symptoms of starvation will be seen here. Okay. So all the signs and symptoms of starvation will be seen here, isn't it? Okay. I hope it is clear. Now, there are two subtypes. One is restricting type. It is more common. Of course, you can understand from the name, restricting type would mean not eating. Decrease. The only method used is decrease in eating. Okay, restricting or decrease eating. Okay. So restrictive type. And second is binge eating. What is binge eating? Eating, yes, eating large food, large meal in less time. Just like there is a new series, you binge watch it. In one night you finish all the episodes. This is binge watching. Okay. So binge eating. And what is purging?
Vomiting.
Self-induced vomiting. Okay, so patient has episode where patient eats a lot, realizes, oh my god, I've eaten a lot, just vomits out everything. Please remember, binge eating, purging will also be seen in bulimia nervosa. But here, before this, the other other clinical features should be fulfilled. Everyone understood what I mean? Binge eating, purging is there, but other three symptoms are also there. Okay, disturbance of body image, fear of gaining weight, and decrease. Restriction of energy intake, food is also there, but there are episodes of binge eating and purging. Okay. So these are the two subtypes. More common is the restrictive type. Treatment, they are very difficult to treat. Very intelligent, very good, female, admitted, you'll find everything fine, but they're not eating. Very difficult to convince them to eat. May require, this was once question recently asked, may require, they will not be, they will not accept food, you may have to admit them. They may require hospitalization. Family will say, doctor, we are fed up, not able to feed her, please admit her, do something. Okay. So they may, so again, one of the reasons will be complication. Is it person is in a state of starvation, nutritional deficit, electrolyte imbalance, so many causes may be there, which may require hospitalization. Okay. One question which was once asked was, a child admitted in a hospital, she is given adequate calories, but she is not gaining weight. Not gaining weight despite adequate calories. Next step, increase the food, increase the amount of food, add anxiolytic, okay, do therapy. Fourth is observe the patient 2 hours after the meals. Observe, because what patient might be doing, you are feeding, goes to the washroom, vomits out. Okay, so you understood, like such question can also be asked. Okay, and of course, in the treatment, you can use drugs like SSRIs. Therapy CBT is of course required, we use it. Okay, right? Just write if you're not. So please remember, hospitalization most of the time may require because of starvation, complications due to starvation. Okay, so you may be asked the indication why you are admitting. So please remember, this is a serious condition. Why? Because it has high mortality. Nearly 40% of the females may even die. Very high because of starvation. Complications of starvation, right? So please remember high mortality. Now, next comes bulimia nervosa. Bulimia means ox hunger, eating like an ox. Okay, bulimia nervosa. Here the person is eating a lot. Okay, again it is more common in females. Much more common in females. Again, it occurs slightly late. It occurs in the like anorexia would occur at 14, 15, 16 years of age. It would occur in the early adulthood. Okay, in the early adulthood. Okay, more common in early adulthood. Okay, which is more common if I ask you, anorexia or bulimia? Bulimia. If anorexia would have been more common, I would have discussed there, isn't it? But please remember, generally when I ask, most of the time we think of anorexia, but bulimia nervosa is much more common. Okay, now here what is happening? It is only having Episodes of binge eating, that is eating large, high amount of food. Eating large amount. Okay, large amount of food. So there are episodes where the patient eats a lot and then realizes I have eaten a lot. So what does the person use? Compensatory behavior. Two types of behaviors person can use. Okay. Person can use behavior like purging. In purging, of course, there may be self-induced vomiting. Self-induced vomiting. Okay. Then patient can use laxatives, diuretics. Patient can use these methods or can use other methods like exercise. Patient eats a lot, does plenty of exercise, starts dieting for a while. Okay, so patient can use any of these compensatory mechanisms. Okay. Yeah. Okay. Self-induced vomiting, very common method. Okay. So here you can see, can now you appreciate difference between anorexia nervosa, binge eating subtype, and simple bulimia nervosa. Here there are only episode, no such problems in self-image, no such thing. In fact, these patients, the BMI of these patients may be normal or maybe even high. Okay. So the BMI may be normal or it may be high. Okay. Right? Now, also, you may not remember, just I am telling you, so basically in anorexia nervosa, there is no such frequency would occur. But here we say, these episodes occur at least one per week for 3 months. So this is how frequently it should occur. It's not that someone is doing once or twice in a month, we call it as bulimia nervosa. Right? So it has to be very repetitive. Right? These episodes occur at least one per week for 3 months continuously. Okay. Now, there are certain complications, especially related to purging. What is happening purging? Patient is putting the fingers in the mouth and vomiting out. So, the acidic content of the food is coming in the oral cavity. What you can see in the image? Dental caries. Very good. Dental caries. So you will find their oral hygiene to be very poor, very poor. Okay. Sometimes because of the acidic content, because of the food, there may be blockage of the duct, glands duct. There may be parotitis. What is parotitis? Inflammation of the which gland? Parotid gland. Very good. Third is, now there may be some electrolyte abnormality. Now let us understand it so that we don't have to mug it up. Tell me, the acidic content of the body is going out. It will be acidosis in the patient or alkalosis? Alkalosis. Very good. So there will be alkalosis. There is hypokalemic, that is decrease in the potassium, along with in HCl, hydrogen and chloride ion are also going out from the stomach. Hypochloremic. Okay, that is decrease in chloride ion. Alkalosis. Again, this has been asked. So now you don't have to just understand the concept, it will become easy. Hypokalemic, hypochloremic alkalosis. Right? Right? Everyone has written this? Very good. Yes, alkalosis. Now, can you appreciate what is happening here? What is this? The knuckles are getting calloused. What is happening? The fingers going, so the knuckles, they are getting injured. And over the course of time, there is callus formation, hardening is seen. So if you see their hand, you will be able to see hardening. What is this known as? This is known as Russell sign. This is known as Russell sign. What is Russell sign? Callus on the knuckles. Why? Because of vomiting, self-induced vomiting. So callus on the knuckles. So these are the complications secondary to purging. If I ask you, can these complications be seen in anorexia nervosa?
Yes.
When? Yes, if it is anorexia nervosa, binge eating, purging subtype. So in the question you may be given these complications, but bulimia is not in the option. Then you have to think of anorexia nervosa, that subtype, right? Now, these patients generally are easy to treat. OPD treatment is generally okay because they accept. Doctor, yes, I know I have problem. Okay. So generally we can use therapy like CBT and we can use drugs. Okay. Drugs like SSRIs can be used and other drugs can be used. Okay. Now tell me, sexual functioning will be, how will be the sexual functioning of these patients? With bulimia. Why decrease? Why it was abnormal there in anorexia? It was abnormal because of starvation. Because of state of starvation, even the endocrinal function of the body are decreasing. So all the hormones will be affected. Here, there is no such thing. Sexual functioning will be normal. So this is again an important difference between anorexia, and it has very low mortality. Low mortality. Okay, it has low mortality. So now you can compare between anorexia and bulimia, right? Okay, everyone has written this, right? Last topic for today. Last topic. Okay, in this also we discuss just one more line about each disorder. Understanding here is very important. It is one of the most interesting topics, if you ask me. When we discuss this, many of us would think, oh my god, I am having this, I am having this. But again, this is disorder we are talking about. Some of us may feel that I am having these symptoms. In fact, all of us may be having some of these symptoms. But don't think that you are having any problem because your functioning is fine. Okay? Personality disorder. Now, before coming to personality disorder, let me repeat again what is personality. Remember, I told you, personality is the way with which we behave in our day-to-day lives. It starts, normal personality starts at 18 years. I don't talk about personality in a child. Okay, so basically personality starts normal personality, not disorder. All of us have a personality, let me tell you. If you now, your friends in school, after 17, 18, 19 years of age, you must have been separated. Now talk to any of your friends. You say, okay, he's still the same. Nothing has changed. Because our personality generally remains the same. Okay. So personality remains same throughout. Similarly, so if I talk about personality disorder, when should a personality disorder start? After 18 years. And personality disorder will also remain stable. Okay, suppose you get a question in the paper that a 30-year-old male for the first time develops some symptoms. Can you call this a personality disorder? Never. So in personality disorder question, parents, family members, friends will say, he was from the beginning like this one. For a long time he is like this one. So this is when they are asking about personality disorder, right? So let us come to personality disorder. It's a pattern of behavior that deviates significantly from cultural standards. Of course, so it's a basically problem in the behavior which is deviating from the cultural standards. Some behavior, I'll talk about the behaviors. Now again, as I told you, it has an onset in adolescent and early adulthood. Okay, so you can just write 18 years. Onset at 18 years. Okay, it may be 17, 18, okay, plus minus can vary. It remains stable through time. Okay, symptoms remain stable. Some ups and downs may be there, but they will remain. and ultimately it's a disorder, so it will lead to unhappiness and impairment. Okay, it will lead to unhappiness and impairment. Okay. So this is personality disorder. Okay, everyone understood when I talk about personality disorder, what are symptoms will be given, how the symptoms will be given. We'll come to what are the symptoms, right? So written this. Okay, we'll wait. Very interesting. I'll ask you to, in the, especially in the celebrities or let us say the politicians or anyone in the social life you think is having such symptoms, we'll discuss. Okay. No. So let's discuss. So there are 3 clusters. Everyone has written this, right? Okay, right first. So basically DSM or basically the personality disorders are divided into 3 clusters. Okay, so they are divided basically into 3 clusters. One is cluster A. Cluster A disorder basically is these disorders have something common, that they are very weird. When you come across someone who is having cluster A personality disorder, you will say that this seems to be a very weird person. Very, you'll not be able to understand that person. So we say that group characteristic is they may be weird or they may be very odd. Something very odd is there in them. Very odd. Quite odd they will look like. So what is first is, let us discuss them one by one. First is paranoid personality disorder. Please remember, I am talking about paranoid, although I am not saying delusion. So there is no delusion, no hallucination. Because if there are delusions and hallucination, it will be a psychotic disorder, right? No delusion, hallucination I am talking about. Paranoid. So what is the important symptom in them? They have a long-standing history of suspiciousness. Suspiciousness, again, I am not saying as at a level of delusion, just suspicious or mistrust. So they will always try to, be suspicious. Okay, always, a lot of time nowadays you are hearing conspiracy theories. So these will be the people who will be developing these theories. Okay, so so if you help them, they will say there must be something in for you. That is why you are helping. They will not trust people. Okay, they will bear grudges. They will bear grudges. Okay, you go and ask for help. Please help me. Someone of a paranoid personality, you say, please help me. The person will say, oh, 2 years back on that Sunday, what you did to me. Now you want my help. So they will hold those grudges. Okay, they will remain, alone, aloof most of the time. So this is paranoid personality, right? Second is schizoid personality disorder. Second, you can write schizoid personality disorder. Okay, they have long pattern of social withdrawal. They are socially isolated. Now please understand, I am not talking about social anxiety. In social anxiety, person develops anxiety. These patients don't develop, they don't want to be social. They want to remain alone. Okay, they don't want to be social. So what will happen? They are emotionally very cold. Very cold. You praise them, you criticize them, doesn't matter to them. They are happy in their own world. Okay, and they lack close friends. Even with their family members, they won't be very much in touch with much. So schizoid personality disorder, right? So if you find in the question a person long-standing history of such symptoms, it's schizoid. Last, again, very interesting group of, write it first, then we'll discuss it next. Last is schizotypal. Schizotypal personality disorder. You can just write PD, PD is personality disorder. Schizotypal. They have very odd beliefs. They will believe in superstition. Okay, superstition. sixth sense, such beliefs they will have. And even you talk to them, they have a very vague speech. They talk about something, keep on, just get bored. What are you talking about? Circumstantial speech. Very vague speech. Okay. And sometimes, yes, they also be suspicious. They may doubt. Again, not up to a level of delusion, but they may also doubt. Okay. So this is schizotypal. So these are the three cluster A. Okay. So you can see, again, they appear very odd, very eccentric, very weird. Okay. So this is cluster A. Everyone has written this. Second comes cluster B. Cluster B. Antisocial personality disorder. So from the name itself, can you make out what it is? Antisocial. They're against the society rules. They're anti. No, not that. They're rebellious in a way. They're antisocial, not asocial. They are against. So they violate the rights of others. You'll find many such people in Delhi. Scratch their car, they come out with a hockey stick. No, as if what you have done, So they can slap anyone, they violate the right. You cannot touch anyone like this. So they will violate the rights of others. They are involved in unlawful activities, gang activities. They may be involved in so many thefts. They may have so many criminal cases against them. Right? And these are also at times very impulsive. They will do things impulsively without thinking the consequence. This may harm them. So they are very impulsive. Many of these may also be engrossed in substance. Substance use disorder may also be common in them. Okay. So they are antisocial. Seen this movie? Seen this movie? Right? He just closes the door of the football match and starts beating. Someone touches his girlfriend, goes and starts beating in the holy. Okay, drinks alcohol as if he's consuming water. Okay, he's operating patient under the influence of alcohol. It is a movie, so he survived. Otherwise, not even one operation would have been successful. Okay, and please see, throughout the substance use throughout the movie, his behavior remained the same. It remained the same. In the end, they showed a happy ending, but let me tell you, there is part 2. The behavior will continue. Okay, classic example of antisocial personality disorder. Read Harry Potter, seen Harry Potter? Yes. Lord Voldemort. Classical example of antisocial personality. Classical. Okay, so this is anti. Now please remember, treatment of all these anti-personality disorders is therapy. Treatment of all these disorders is therapy. Please remember this. I am not saying of all these disorders is therapy. All A, B, C, every. Drugs we can use if we have to manage some symptoms. Okay. Otherwise, therapy is the treatment of choice for all. This I want you to remember. This I want you to highlight in your notes. You can expect a question on this soon. You can expect a question on this soon. Very soon you will find a question on borderline personality disorder. Borderline personality disorder. Very soon you will find. More common in females. Okay. More common in females. No, they have unstable relationships. Okay. No, one day you will be their best friend. You do something good for them. On the other day, you say something bad. They'll be the worst enemy I have. Okay, just go out from my side. So they have very unstable relations. They are also very impulsive. Please remember this. I am discussing every disorder, but I am also telling you in which you can expect a question. Highlight this. If you don't want to revise everything, at least revise those points. You can. This is important. You can expect a question from this. Okay. So you can expect. They also have recurrent suicidal behavior or attempts. You see their wrist. A lot of superficial marks may be there. They may not attempt it severely. Just they will threaten, I will end myself, don't do this. They will threaten along. Okay, they may not ultimately, do it, but superficially they may cut. They may say, doctor, I feel I am empty from inside. There is a chronic feeling of emptiness I have. But they will have people around, but they will say, no, doctor, I feel I am empty. And their mood also may be unstable. They will have anger outbursts without reasons, without any reason. Okay. So the question may be a 24-year-old female newly married brought into the emergency with suicidal attempt. When you talk, she's having unstable relationship in the past, complains of feeling of emptiness, have frequent, mood issues, diagnosis, borderline personality. This is very important. Out of all these, I am again telling you, very important treatment also. One specific therapy, all the above we use CBT. For this one specific therapy name you should remember. It is known as dialectical behavior therapy. Very important. Dialectical behavior therapy. Very important. This therapy of choice in borderline dialectical behavior therapy. Again, I am emphasizing, at least read this in personality because you may get a question on this. Okay. Now, next is, everyone has written this. Next is history on it. Just remember the names that we. Let me ask you, which of the following is not a cluster A, cluster B, cluster C? That's it. Simple question. History on it. What is histrionic personality? They are very dramatic. They want to be the center of attention. You go in a party, you may find someone very loud, wearing such attractive clothes. Okay. Any actor, any male actor you can think of? I'm not saying he's having disorder. No, because he's married to Deepika Padukone. His movies earn a lot, so his functioning is fine. But yes, some traits are there. No doubt. Okay, so this is histrionic. That she may also have this also. She may also have this also. This one, the next I'm talking, narcissistic personality. Yeah, I'll show the last slide. This is. Okay. Narcissistic means. Okay, write it down, I'll explain. Just a few more minutes, then we'll end it. Okay. Salman Khan, any traits you can find? Before other than that? Right. Isn't it? If you see his life history, you may find some. Someone does not, he does not just say something else, he does not let him be in the industry. Okay. And then narcissistic. Narcissistic means self-absorbed. Okay. So basically there is an increased sense of self-importance. I am the most important person. Nothing else matters. Okay. They are very exploitative. They will exploit their juniors. Do this for me, do that for me. They will like people who butter them. They will have people who will just praise them. And they are very arrogant. Especially in our profession, if you start, PG, when you will meet your HODs, many of them try to look about these characteristics. Because when you're working as a PG, you may be able to know the person even better. Okay. So, they will just want that everyone should praise them, nothing else. I am the most important person. Okay. In fact, this term narcissistic was derived from a Greek mythological character Narcissus. What happened was he saw his image in the pond, reflection. He fell in love, drowned. Okay, so this is narcissistic personality. Last cluster, he drowned because he was in love and just he drowned. He wanted to touch and drown. Cluster C, avoidant anxious personality disorder. At least remember these 1, 1, 2, 2 lines which we have written, just write them. And remember the name. The most important I am already telling you. Okay. So they are avoidant, they are anxious. So the cluster C is they are very anxious people. Okay. So they avoid, they fear criticism and disapproval. So they will not tell their, tell their thoughts in group. What if someone criticizes me? What if someone disapproves of me? And they have a feeling of inadequacy. They have a feeling that I am not adequate enough. So they will, just say yes to anyone. Okay, they will not say no. Okay, they will try to hold on to the friends they have. Okay, so this is avoidant anxious. Right? Second is dependent personality. Okay. Again, from the name itself, you can see they have difficulty in making everyday decisions. Please remember, I am not saying the difficult decisions. Whom should I marry? What job should I take? Of course, these are the decisions we will consult, we will discuss. What dress should I wear today? I don't know. I should call my mom. What should I eat today? I should ask my friend. So, taking decisions of daily routine, they have difficulty. So, they are dependent on the other person. This is dependent personality disorder. The last again I want you to remember. Okay. So the last, everyone has written these. This one I want you to remember. At least in detail. This is obsessive compulsive personality disorder. Please remember the name is obsessive compulsive, but there are no obsessions. There are no compulsions, because if there are obsessions and compulsions, it will be OCD. Very good. This is also known as anancastic personality disorder. Okay. Okay. Obsessive compulsive personality disorder. What happens here is they are preoccupied with rules and details. Everything should be in details. Everything should be in rules. If you give them a task, give them 20 steps, they will follow all the steps. Someone tells them, oh, I can do it in 10 steps. No, no, no. I will follow the steps. So they are busy in these rules and regulations. They would want to do everything with perfectionism. This does not mean that they are able to. So much so they are involved at the ultimate, they may not start even the task. To study, I should have red pen, blue pen, pink pen, all the books. So much so, 2 hours later, not even single page started. Okay, they are very inflexible. Okay, so they will not change. They will not try to change. The way they want to do things, they will do like this. They are very rigid and stubborn. Any actor you can think of? If he has to make a movie, he will gain weight, then he will lose weight. Even if it takes 4 years, 5 years. Okay. So, but yes, so a lot of time, traits are there, but it is not a disorder. In movies on 400, 500 crores. So, some traits are there. Okay. So, this is obsessive compulsive personality disorder. These were the important personality disorders. So, what all important disorders you should definitely remember? Borderline personality disorder and obsessive compulsive personality disorder. Two words about Sigmund Freud. If we are studying psychiatry, we should not forget this gentleman, Sigmund Freud. I'm not going. Again, he's known as father of psychoanalysis. Father of psychoanalysis. Psycho means mind, analysis, analyzing the mind. So he tried to, what he would do is, he would ask his patient to lie down on the couch and speak whatever comes to his mind. 20, 30, 40 years he studied the patient and gave so many theories. Will not go into details of the theories. Important things, 2 important terms I want you to remember. Sigmund Freud. One is, what do we mean by transference? Transference. So in psychiatry, when we talk to the patient, we talk in detail, spend so much time. We talk about so many things which that patient might not have discussed with anyone else. So sometimes what happens, patient develops feeling. Transference is conscious or unconscious feelings of the patient towards the towards the therapist. Conscious means patient is aware. Unconscious means patient is unaware. Please remember, I am not saying these are positive feelings. These can be positive, these can be negative. Okay, so these are feelings of the patient towards the therapist. Okay, so for example, a patient, a 30-year-old female patient goes to a psychiatrist who is 50 years of age. After many sessions, he says to the psychiatrist, "No, you are like my father, you are very caring, you are always good to me, always help me." So these are positive feelings. Sometimes let us say another case, same age group, patient may say, "Doctor, you are like my stepfather, very mean, very bad person." These can be negative also. Okay. But transference is helpful at times because it is telling the inner conflicts of the patient. Okay. Maybe she is having some conflict related to her father. Okay. Then second is counter transference. What is the counter transference? Opposite. What is happening? Yes, conscious or unconscious feelings of the therapist, okay, towards the patient. Okay, so doctor may develop feelings towards the patient. This is not right. So if you feel that you have developed feeling, you can refer the patient. Okay, transference is helpful. Transference, if someone develops, not that you have to transfer the patient, it is helpful. You can use it in the therapy. Okay, but counter transference, if it develops, then you will see love you Zindagi, right? Alia Bhatt, yes. Did Alia Bhatt develop transference towards SRK therapist? Yes. Did SRK develop counter transference? Why? How? He did not reach that party where she invited. That in the end, if you have seen the movie, then that is suggesting that he was a good therapist in the movie. He did not develop counter transference. Okay. So this is counter transference. Just one point. There is something known as mental health. Just remember this Mental Health Care Act 2017. MHCA 2017. There is a new act in India, MHCA. There is a new act in India, MHCA. Basically, it is telling us dealing with how to deal with it is not telling which drug to give. It is telling us because again, mental illness may also have some legal impact. So earlier there was a Mental Health Act in 1987. After a long time, we have a new act, and this is, you can see, relatively new act. Up till now, they have not asked question. They will just simply ask the question, which is the new act? Mental Health Act, Mental Care Health Act. They will just change the name. It is MHCA 2017. Okay. Just remember here, it has decriminalized suicide. It has decriminalized suicide. What do we mean by decriminalized suicide? Earlier, if someone would attempt suicide, he would be punished under which section of IPC? He will study 309. Okay, so someone attempted suicide, he escaped, he survived. Now police will put a case on. Right? So it was criminal offense to commit suicide if you survive. But what would happen? Many a times, what would happen? Person would not tell you. Would say, "Doctor, I did it accidentally." So a lot of patients with psychiatric problem would not come up. Now they say someone is committing suicide, that means he was in a lot of stress. Don't criminalize that person, so that at least that person may come for treatment. You may be able to help the person. This is a very important. There are many things which have been put, but at least remember this. MHCA 2017. Very, very important. Right? Few questions we'll discuss. I'll just repeat the questions. This question we had discussed yesterday. Roadside accident, fearful driving, 6 weeks after the incident, diagnosis, PTSD. 6 years, read this question. No interest in daily activity, not engaging with children of age group, 2018, autism, very good. Again, 2021 question, panic attack, not a symptom of panic attack, very good. Singing, depression, very good. Next, again 2021, earliest or most common symptom, very good, tremens. Treatment, benzodiazepines plus if there is thiamine also. Right, good. Now, next question. Again, very, very important. Please read it again. Those who read this. A patient consumes alcohol daily, develop global confusion, ataxia, and other symptoms. Management. What is the diagnosis? Tell me the diagnosis. It is not withdrawal. It is Wernicke's encephalopathy because of thiamine deficiency. Give thiamine. Because in the option they will also give benzodiazepine. So look, 2 questions, and if you will see in every exam, 1 question of alcohol, every alternate year, 2 questions coming from this topic. Very, very important. Okay, this we have already discussed. Mild depression treatment is CBT. Okay, okay, and this one we have already discussed. Lithium, it is abstinence and alcohol agents. Okay, so if you have any, read psychiatry. If you get any doubts, any queries, let us know. Please remember, just give me 2 minutes. It is not the strongest one, who survives or the most intelligent, but the one who adapts. So there are so many changes occurring nowadays. If you are able to adapt, you will survive and you will do well. Okay, because change is the only constant. Only constant. So never give up. Even at the last, never give up. And you may succeed. Okay.